Oh dear.
Hello?
Hello, can you hear me?
Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách, nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021.
Okay, good morning, everyone. Yeah, very nice to see all the speaker and then colleagues today. And today I'm the Dr. Phạm Như Hùng, the chairman of this session, and co-chair with me the Professor Phạm Quốc Khánh from the Vietnam Heart Association. And then today we got the very four famous the speaker in Vietnam. Almost is a foreigner, but is famous, so famous. And then we very soon to start with the Dr. Thomas Bum, my very close friend with me. She will present the background in the CRT therapy update in 2021. Dr. Thomas Bum, please.
Okay, how do we look? Is it sharing? Can you hear me?
We can hear you very clearly.
Oh, great. And can you see the slides? Well, today I want to thank the organizers of the symposium for inviting me to speak today. And my subject today will be cardiac resynchronization therapy, or CRT. Oh, I'm sorry. There we go. The left bundle branch block is a very special anatomic feature of the heart. The left bundle branch synchronizes the left ventricle during normal heart rhythm. Its many branches and specialized conduction fibers enable the activation signal to spread rapidly and simultaneously across the left ventricular endocardium. Left ventricular dyssynchrony occurs when there is left bundle branch block or when there is competing source of ventricular activation, such as right ventricular pacing. During right ventricular pacing, activation spreads slowly from the right ventricle across the septum and toward the free walls, just as it does during left bundle branch block. So both conditions, right ventricular pacing and left bundle branch block, both cause left ventricular dyssynchrony. Now, the prognosis of left bundle branch block is a serious matter. A number of studies from countries such as the United States, Japan, Sweden, and Italy have shown that people with left bundle branch block have a worse outcome. The Framingham study from Massachusetts showed 50% greater risk of cardiovascular death within 10 years of the onset of left bundle branch block, etc. Japanese case control studies showed 3 times greater mortality from congestive heart failure during follow-up. A Swedish study showed twofold risk of death, and an Italian study of heart failure patients found a 25% incidence of left bundle branch block in heart failure, and that patients with left bundle branch block and heart failure had a much higher risk of all-cause mortality compared to people with heart failure without left bundle branch block. And so therapies were developed. I think this was very imaginative. This is biventricular pacing, which first started to appear in about the year 2000. And this biventricular pacing is accomplished by having an electrode lead in the right ventricle and an electrode lead in a branch of the coronary sinus, so that it's in contact with the left ventricular epicardium. Each ventricular contraction is activated by fusion of activation wavefronts spreading from each of the 2 separate pacing sites. The fusion produces a narrower QRS complex and presumably more left ventricular synchrony than pacing at either single pacing site. And you can see in the cartoon representation is that the complexes from right and left ventricular pacing separately, the complexes are wide and the complex is narrow. When the pacing is simultaneously and you produce a fusion activation in the left ventricle. Now, a number of randomized clinical trials were undertaken, which confirmed that this kind of approach to treating patients with left bundle branch block and heart failure could lead to a better outcome. In most of these cases, patients were enrolled not only with left bundle branch block, but also with right bundle branch block and IVCD. And in these cases, the patients were randomized to different treatment arms. In Miracle, they were randomized to CRT pacemaker versus conventional medical therapy, and compared to patients receiving optimized medical management, patients in the CRT group experienced greater improvement in subjective quality of life, 6-minute walking distance, greater reduction in functional class, fewer hospitalizations, and fewer primary endpoints, which in this case was a composite of death or a hospitalization for heart failure. In the CARE-HF study, this was a study in which patients were randomized to optimized medical management alone or medical management plus a biventricular pacemaker. And I want to point out that these first two randomized trials were with pacemakers, not with defibrillators. So these patients were not getting the survival benefit of defibrillator therapy. All the improvement was based on the resynchronization that was going on. But in these patients, the primary endpoint, again, a composite of death from any cause or unplanned hospitalization for a major cardiovascular event, was reached in 159 patients in the CRT group, as compared with a much higher number of people having death from any cause or unplanned hospitalization of 224 in the medical therapy alone. Again, a big, very significant improvement in CRT as opposed to medical therapy alone. The companion study was actually two studies together. There was a branch of, in this study, it was designed so that resynchronization using a pacemaker could be compared with optimal pharmacologic therapy. And now in this study, there were patients who received a CRT defibrillator, and their outcome could be compared with that of patients receiving optimal pharmacologic therapy. And the risk of primary endpoint from any cause or hospitalization was reduced by 34% in the pacemaker group and 40% in the pacemaker defibrillator group, as compared to patients who were treated with optimal pharmacologic therapy alone. So it did suggest there might be a little bit better response in survival, at least, for patients who received the CRT defibrillator as opposed to patients receiving the CRT pacemaker. But the two of those groups could, the study was not powered with enough patients to make that comparison firmly. Now, in MATED CRT was different patients were now randomized to receive a plain defibrillator without CRT or a defibrillator with which could provide CRT. And these patients, during follow-up of 2.5 years, death from any cause or a non-fatal heart failure event occurred in 17% in the CRT ICD group, as compared with 25% of the ICD only group. So CRT again was beneficial in this group of patients with mild heart failure symptoms, but ejection fraction of 30% or less, and Q restoration of 130 or more. Again, still in the trials up to this point, they were being done in people who had not any white complex from any cause, whether left bundle branch block, right bundle branch block, or IVCD. Despite those inclusion criteria, the benefit is seen in that entire group. And the benefit was driven by a 41% reduction in heart failure events in the CRT, the patients who received CRT. Now, in a study reverse, was a little different. Every patient got a CRT system, and in this case, the randomization occurred in that some of the patients the CRT was turned off, and in some of the patients the CRT was left, and the other patients the CRT was turned on. And what they saw was that there was little remodeling or good clinical response in non-left bundle branch block patients who received CRT. In the left bundle branch block patients, furthermore, there was no benefit in patients who had Q restoration less than 120, and the chance for benefit was less in patients whose QRS was 120 to 140 than in patients with a QRS of greater than 140. So as a result of these studies, the Strauss in 2011 proposed new criteria for diagnosing left bundle branch block in order to improve the differentiation of patients who would respond to CRT from patients who would be unlikely to respond. And the main difference in Strauss's criteria is that in order to diagnose left bundle branch block, the QRS duration in a female should be greater. I'm sorry, in order to diagnose left bundle branch block, the QRS should be greater than 130 milliseconds in a female or 140 milliseconds in a male. And then there should be slurs or notches in the QRS complexes in the adjoining leads on the electrocardiogram. When you do this, then another group, this is in Strauss's group, this is a group of Dr. Jastrzębski, and he did a very innovative study, I thought. They had 552 patients who had received CRT, and they looked at the goal was to see how each of 4 different electrocardiographic criteria systems, how they would perform in differentiating responders from non-responders. In the upper left panel, you see conventional criteria for diagnosing left bundle branch block, and the people who were diagnosed with left bundle branch block in blue did about the same as people who did not have left bundle branch block in red. There was almost no separation of the curves. Marriott, who wrote a famous textbook in electrocardiography and had a definition of left bundle branch block, Marriott's criteria were not much better than the conventional. There's still not much separation between the patients who were defined as left bundle branch block versus those who were not. Then there were criteria from the World Health Organization and American Heart Association. They had much better separation between the performance between the people with left bundle branch block under their criteria, the blue curve, as opposed to the group in the red curve. And finally, Strauss's criteria was the best. Strauss's criteria diagnosed left bundle branch block in a way that differentiated the people who responded to CRT, differentiated them much more clearly from the patients who did not respond to CRT. These were, all 4 panels looked at the same 552 patients, but with different electrocardiographic criteria. And so far it looks as if the Strauss criteria are helpful at determining who's going to respond to CRT. And I think this is helpful. Now, another thing I mentioned, I've been talking about left bundle branch block. I'll talk briefly about right ventricular pacing, which creates a type of left ventricular dyssynchrony that's similar to that which is produced by left bundle branch block. And 2 studies in 2002 showed that right ventricular pacing did cause, these studies were interpreted as showing that right ventricular pacing would cause heart failure. That was MEDA2 and DAVID. And in MEDA2, for example, a group that received a defibrillator, which had pacing capability, had a lower risk of death than the group that didn't receive the defibrillator, but the group that received the defibrillator had a higher risk of heart failure than the group that did not get a defibrillator. So it appeared as if pacing might have been the difference that caused the increased risk of heart failure. This was also suggested by the trial DAVID, in which all patients received a dual chamber defibrillator. Half of them were programmed to receive very little pacing, and half of them were programmed to receive a lot of pacing, so that one half got 3% of their beats were paced, the other half, 60% of the beats were paced. The group that got a lot of right ventricular pacing from these defibrillators had a lower survival rate free of hospitalization for heart failure of only, their rate was only 73% chance of survival free of heart failure. The other group had an 89%. The group that didn't get much pacing had an 89% survival rate free of heart failure. Now, in patients who need right ventricular pacing or need ventricular pacing of some sort because of heart block, These patients were found in block HF, patients who had an indication for ventricular pacing. You couldn't get away from it. They had a much better outcome with biventricular pacing than with right ventricular pacing alone in the block HF trial of 2013. Now, a couple interesting studies, which were not large randomized trials, but are very provocative, are the NEOLIFT studies. In the first NEOLIFT study of 2015, 102 patients with non-ischemic dilated cardiomyopathy and ejection fractions less than 35% were given optimized medical therapy for 3 months. 70 of the subjects didn't have left bundle and 32 did. After 3 months of optimized medical therapy, the ejection fraction improved to greater than 35% in 39 out of 70, or 56% of the non-left bundle branch block patients, but only 2 out of 32 of the patients who had heart failure and with left bundle branch block, which is significant. Now, it seemed as if the people without left bundle branch block had a different type of cardiomyopathy that responded to medical management than patients with left bundle branch block. And then a next interesting thing is the people with left bundle branch who failed to respond to medical management received CRT, and they had a dramatic response to CRT, even though they had not responded to optimized medical therapy like beta blockers, ACE inhibitors, or spironolactone. With CRT, these same patients improved from ejection fractions of average of 23% to 43%, and 8 of the patients with left bundle branch block had so-called CRT super response, defined as the post-CRT ejection fraction greater than 50%. That leaves the question, could it be that left ventricular dyssynchrony due to left bundle branch block is unresponsive to standard guideline-directed medical management, but is very responsive to CRT? Are we dealing with kind of a unique cardiomyopathy? Another study from the NEOLIFT investigators looked at whether how important it was as to the time that elapsed between the diagnosis of left bundle branch block with cardiomyopathy and the time to implant. If that time was less than 9 months between diagnosis and implant, the success rate was 5 times higher than in the group that was the time was greater than 9 months. So sometime maybe around 9 months, these patients it appeared that these patients were developing irreversible heart failure and left ventricular dysfunction, at least in this small group and small study that was suggested, and I think bears further looking. Now, at the same time all these are happening, I'm not going to discuss these details. I'm not an expert in these, but I'm impressed that at the same time these are happening, investigators are looking at the power of CRT in animal models. These are animal models, and they, in these studies, they are finding that CRT changes the cells, the myocardial cells. It changes their cellular structure and their molecular structure, which is fascinating and is going to be very interesting to follow the progress in these areas. So in conclusion, compared to patients with cardiomyopathy due to left bundle branch block, CRT is less helpful or even not helpful in patients who don't have left bundle branch block or whose left bundle branch block produces a QRS restoration less than 130 milliseconds in females and less than 140 seconds in men. New ECG criteria, that is the Strauss criteria for diagnosing left bundle branch block, may be better than previous criteria at differentiating patients who will respond well to CRT from patients who will respond less well and may allow us to avoid implanting devices, CRT devices, in patients who probably won't respond. Left bundle branch block associated cardiomyopathy may be resistant to optimized medical therapy, but this cardiomyopathy can be reversed by CRT, or in the case of right ventricular pacing, by reprogramming the pacing parameters if the patient's not dependent on right ventricular pacing. But left ventricular systolic dysfunction may become irreversible if dysynchrony remains untreated for too long. A couple of questions for the future will be, should CRT be offered to patients who have heart failure with mildly reduced ejection fractions, and not just to patients with severe reduced ejection fractions? And will His bundle pacing and or left bundle pacing, which we'll hear about later in this session, will that deliver CRT more effectively than biventricular pacing? Thank you very much.
Okay, thank you, Tom, for a nice presentation. And then you review from the past to the future of the CRT. And then maybe we come back to the question after the 20 minutes after the Dr. Trần Thống presentation. And now we would like to invite the Dr. Trần Thống from the US and present the semi-intrinsic CRT. Then we get the effect CRT by only the RV pacing. Please invite the Dr. Trần Thống. Dr. Trần Thống.
As a pathway to effective CRT with improved device longevity and reduced AF in patients with left bundle branch block and good ARV conduction. This is my disclosure. Traditionally, biventricular CRT has been used for the treatment of heart failure patients. Recently, LV-only pacing has been proposed, and its main advantage is that it has improved longevity since there's no RV pacing, and it's reduced AF due to reduced RV pacing. And this is available in the high-end new generation device of CRT-D and CRT-D. Let's look at the autonomic nervous system. The ANS regulates the cardiac output in a closed-loop feedback system. It uses input from the baroreceptor, and it acts on the cardiac output through modulation of chronotropy, dromotropy, inotropy, and a few other things. Let's look at the heart conduction. We have the healthy patient here where the dromotropic modulation will affect both the RV and LV signals. In the case of left bundle branch block, only the RV arrival is modulated by dromotropic influence, but no, the LV, so deposition also follows the RV. In the case of biventricular pacing here, the dromotropic modulation are ineffective due to the 98% pacing goal, and thus it requires that we pace very early in the cycle. The indication for this therapy is a CRT a patient with left bundle branch block and good ARV conduction. So the patient in this spot is two patients with Biotronik CRT-Ps, and they will switch to LV-only pacing to improve device longevity. And there's a CRT-D patient which essentially was implanted from the beginning with LV-only pacing for increased device longevity. The setting of this device, they all have use LV sensing to avoid pacing on the LVT wave. So essentially we have demand pacing in the LV. They have RV sense trigger, where an LV pace is triggered whenever there's an RV sense. All patients are remotely monitored using the Biotronik home monitoring. In this device, especially in the Biotronik CRT-Ps, nightly around 2 o'clock, the AV delay is increased to 300 milliseconds for 35 cycles, allow RV sense measurement. So the event rate is 0.04% daily. In Biotronik CRT-D, this happens 4 times a day, so the rate is 0.16% daily. This is RV sense trigger. Essentially, nothing much. The LV pace always happens when the RV sense is late. But no, if the RV sense arrives before the scheduled LV pace, then it triggers an LV pace with a very short delay, typically around 20 milliseconds. So let's look at the data. So we have the first CRTP patient here, which has been followed for 3 months. So this is the 3rd month follow-up. And so the data we present here are doing bi-V pacing. We have the AXV sense histogram, where X here stands for sense of pace, and then we have some basic statistics here. Notice here that you have A sense, V sense here is 0%. So that it's a very small amount, typically less than 0.5%. And but no, even though this is small, there's still breakthrough RV sense. And actually, all the A sense, V sense are summarized up here. The sensing test here provides a reference, the 0.04%. Then we have the Wenke back about the AV delay. But of concern are the short A-sense RV sense, which we believe are the ANS reaction when cardiac output demands are not met. But no, in this case, they're very small because the cumulative of this thing is less than 0.04%. It's less than the sensing test. Let's look at the second CRTP patient. This is 7 months after the implant, and it's again doing bi-V pacing. In this case, we have a 1% A sense, V sense, and in this case, we're seeing that the sensing test again provides a reference. We have Wenke back around 160 milliseconds. Of concern are the A sense, RV sense, the ANS reaction when hemodynamic demand are not met. So in this case, we have a total maybe up to about 0.5%, and they're half and half between the Wenke back and then the ANS, the short RV, A sense, RV sense. Let's go back and look at the first patient 12 days after the LV only programming. In this case, the A sense, RV sense is now 1%. It was 0% before, but no, most of it is in these 2 columns, which are due to the RV sense trigger. So those are on purpose that we had this thing. But the key finding here is that there's no visible short A sense, RV sense. There's nothing up here. Even though this shows you the level. This is 0.04%. So this means that the ANS is satisfied with LV only pacing. This is after 2 years and 3 months at the last follow-up. You can see again there's nothing in here, and the A sense RV sense trigger is high because it's the patient does a lot of exercising and have a frequent episode of high heart rate. But you may say the reason that it's nothing here is it could be due to the large level RV sense trigger. Could be, but no. Let's look further. Let's look at the second patient 7 days after the LV only pacing. In this case, we have these 2 high columns, a Wenke back and what we call random RV sense trigger. We come back to this later. So using the sensing test data, this is very quiet at short range. This is 0.04%. Remember the cumulative. The 8 month post LV only programming, in this case, this is 0%. So really, all this thing are less than the sensing test here. So it's less than 0.04%. It looks like it's a lot, but it's really not that much. So it's still very quiet on the short interval front. And this is an intermediate histogram, and you can see there's almost nothing here. The CRTD patient, unfortunately, 4 days after implant, went to a clinic and got a new prescription. It became bradycardic. So essentially, the therapy was reset. So this is a follow-up after 11 days with sensing tests, 0.16. The measure 4 times a day. Short intervals and Wenke back interval may be at the same level for a total of 0.5%. Less than 0% here. So they look about the same. So it's a fairly high level, but still, so it's not a lot. Unfortunately for this patient, we have a lot of number of misprogramming, and we discussed it, mentioned this a little bit later, and we have no recent follow-up due to the COVID. And this is the IgM, but no, we have remote monitoring, and this is the data from the IgM data. We receive almost weekly reports, IgM reports, and we come back to extract the A-PACE V-Sense and the A-Sense V-Sense. Notice this plot of the median value of each record again with the standard deviation. You can see that there's a big shift, a big change here from the left to the right, and this is what we call, it is an indication that there has been a remodeling of the autonomic nervous system and with A-PACE, and this happens at day 104. And essentially in this case, the therapy reset allow witnessing the ANS remodeling. It's not visible in other patient because it happens too fast. LV only with AVD of 20-30 milliseconds shorter than the IV sense leads to remodeling of the autonomic nervous system with significant reduction of the short interval A-sense IV sense, typically associated with unmet cardiac output demand. And let's look at the ladder diagram. In this case, we have the fixed LV pace here, but no, the dropomotropy can modify when the RV deposition happens. And in the process, no, essentially we have the amount of desynchronization changes depending on how the dromotropic action happens. So in a sense, dromotropic action now is leading to managed dysynchrony. We're managing the dysynchrony. For example, if you want you need better cardiac output, you pull it to the left. If you don't need much cardiac output, you push it to the right. So what happened is that when the ANS remodel, it is learning how to do this managed dysynchrony. This is different from the knee-jerk reaction we seen earlier because it's organized, and we're going to have an example a little bit later. Since modulation of the ARV delay is just shifting the time of the event, it is effortless, so it doesn't require any more energy in the heart. So unlike chronotropy, inotropy increase that require additional energy from the body, this is effortless. Let's look at the diagram. In this case, the LV pace now is no longer fixed. It tracks the what's happening with the RV sense, the RV deposition. So we essentially have LV and RV sync to a few milliseconds. How do we know that the patient has RV sense trigger? What we have is the standard statistic is that we have the red trend here a little bit over 24 hours, and we have the percent pace. The pace here is the LV pace because we don't have RV. So what we see the curve of the V pace here, if you measure from the bottom up, that's a percent of LV pace. But when you have an RV sense event, it supersedes in the device. It supersedes the LV pace, so it's recorded as an RV sense event. So this is actually if you measure from the top, this is the RV sense trigger rate. And notice that when you have a lot of RV sense trigger, you have a high rate. This is associated with a high rate in this case here. Okay. So this is an interesting example here. The patient is asleep, so it's the heart rate is very low. So in this case, we have a lot of A-pace. So what we're seeing here is the transition from A-pace to A-sense, and the managed dysynchrony managed dysynchrony plus the RV sense trigger is used to give the heart an energy kick. So it's like a priming effect. This is more details. What I've done is that I've taken the IgM waveform here at those two places, so that's where they are, and this enables me to measure the time from the A pace to the peak of the R wave. So in this case, we start out with 184, 178, more or less the same. Then it's pulled in at 153 and 140 where we have the RV sense trigger. So we can see deliberate A pace RV reduction leading to RV sense trigger than A sense. So the managed dysynchrony is a two-step process. In this case, it went to 153 and then 140 for the RV sense trigger. There are actually two types of AV sense trigger. There's a random AV sense trigger. Since ARV is random, if the current value is close to the AVD, it may occasionally shorten enough to cause AV sense trigger. So this is observed when the overall AV sense is 2% or less. Then you have ANS initiated AV sense trigger, typically associated with large A sense V sense. So LV only with LV AVD about 20 milliseconds earlier than LV sense has been named semi-intrinsic CRT, and intrinsic because the ANS is in charge, semi since it only controls the RV. The case can be made that with LV only pacing, the problem of the always late LV deposition, that is unmanaged desynchrony, has been solved with a fixed LV pace and with RV deposition used to manage desynchrony. But no, one of the problems we found out is that not the CRTP patient, number 2 patient, does not have a sense ANS RV sense trigger. It has a random RV sense trigger. The RV electrode position, when we look at it, the RV electrode position yielded RV sense late in the intrinsic deposition cycle. Looks at here, it's almost close to the peak. And if you go to compare this with the first patient, it happens a lot earlier. So anyway, in this patient we have no RV sense trigger, the RV electrode is not used, then why do we need them? This had led us to propose a dual chamber CRT, which is based on the dual chamber pacemaker with lead in the RA and LV. The index patient in this case is 20-year-old female. It was monitored remotely for 24 months. She went from NYHA 3 to NYHA 1 in 3 months. Notice the level of activities here, 0% here and greater than 20%, which is fairly high. This patient has chronotropic incompetence, that's why they have a lot of atrial pacing. In this case, we use a Biotronic AVT6 DRT, not a basic device, because we needed the home monitoring. The projected total service time is 8 years, 11 months for this dual chamber devices, compared with the AVT, the CRTP, which is 7 years and 9 months, even though the battery 26% larger. This number is come from we're using home monitoring, and there's a 25% atrial pacing. The last one I want to talk about, a new CRT. The CRT patient was mistakenly programmed to a long LV-AV delay. They were programmed to 185, whereas actually when we measure it's 152. So it was a mistake. But no, this enabled us to, by luck, then we discovered what we call RV sense trigger CRT. We did not recognize this thing initially, but the two ventricles now are synchronized by the RV sense trigger. So just is as in a healthy person, but with a small delay between the two ventricular deposition. So if you look at the bell curve here, it's physiological process. The proof that the autonomic nervous system can modulate ARV to meet cardiac output demand in LV-only pacing. So it's not tied to rate, so it's an effortless change in CO. So what's happening when we're shortening the ARV and LV pace, it increased atrial contribution and reduced mitral regurgitation. So essentially it's increased cardiac output. So in conclusion, I can say that LV-only pacing is a pathway to improve CRT in patients with left bundle branch lock and good ARV propagation with existing device. We don't need the new Tessetta device, but with the appropriate program. We mentioned the semi-intrinsic CRT, then we talk about the RV sense trigger CRT. But I think that right now my thinking is that this should be the first choice for LV only pacing. We started with this semi-intrinsic CRT, but right now we're moving to this thing. And then there's a dual chamber CRT for financially challenged patients. In Vietnam, we figure that with the national health coverage, the out-of-pocket cost would be 0.81 average annual income versus 2.45 for the CRTP. And this is still a small exploratory study limited by the pandemic, causing no follow-up for the past 11 months, only remote monitoring. But this has given us time to do deep analysis to understand the effects. And actually, the results presented are very new. A month ago, we couldn't present the insight that you're seeing here. So anyway, we still need your support for this made in Vietnam CRT. The device need LV sensing for demand pacing, and we would recommend RV-Sense Trigger CRT, which is very simple to program and can be done by the cardiologist. And then we also would like to push the dual chamber CRT, but an engineer's need for programming. And then what we started out with this semi-intrinsic CRT, we believe that it should be moved to a backup for this RV-Sense Trigger CRT. Thank you for your attention.
I would like to invite Professor Song Teo. Please.
Good afternoon. I'm Dr. Teo Wee Seong. Thank you very much for the invitation. And I will be talking today about the conduction system pacing in this symposium on advances in cardiac pacing. As you know, the conduction system as the His bundle and goes down to the right bundle and then the left bundle. This is on the right side. On the left side, there is the left bundle system, which is there. Here in this slide, you can clearly see that the His bundle is on an average about 2 centimeter and about 4 millimeter in diameter. So this is a very narrow region in the right atrial left ventricular part of the membranous septum. The left bundle, however, is a much bigger structure on the left side. And here it is easy for you to target the left bundle because it is a bigger area and it is between the junction of the membranous and muscular portion of the left side of the ventricular septum. The question is, why conduction system pacing? Well, RV apical pacing was the standard of pacing and it is generally easier. However, it is associated with this synchronous pacing and in some cases resulted in pacing-induced cardiomyopathy and heart failure. Also, there's a much higher incidence of atrial fibrillation and hospitalization. And as such, alternative pacing methods such as RV-OT pacing were done. And this, however, failed to show any significant improvement. So you can see here in the review that the incidence of pacing-induced cardiomyopathy occurred in about 10 to 40% of the patients. What were the predictors of pacing-induced cardiomyopathy? Well, the percentage of right ventricular pacing was very important. Initially, it was thought to be about 40%, but recent studies suggested as low as 20% of ventricular pacing was enough to cause pacing-induced cardiomyopathy. Also, the baseline LVEF and the pace QRS duration were predictors that the patient may develop pacing-induced cardiomyopathy. What is conduction system pacing? Basically, it is trying to get the conduction system itself either at the His bundle or lower down at the left bundle branch area. So by definition, His bundle pacing will be capturing the His bundle directly, whereas left bundle pacing will be trying to capture the area of the left bundle, which is a wider anatomical structure. Occasionally, there's a term left ventricular septal pacing where there is deep septal pacing, but there is no capture of the left bundle branch itself. The advantage of conduction system pacing is that it is definitely a more physiological pacing system. Conduction occurs through the native His-Purkinje system. There is hence no induction of pacing dyssynchrony, and it can also correct bundle branch block. So these are examples of patients with His bundle pacing. You see very narrow QRS complexes. Left bundle branch block pacing, the QRS is slightly wider, and there is a right bundle branch type of morphology on it. His bundle pacing was first shown to be feasible by Dashman in a publication in Circulation in year 2000, where they located the His bundle and then were able to demonstrate that His bundle pacing was feasible, and they showed improvement in the heart function with this technique. However, the tools at that time were rudimentary and it was not easy to do. Subsequently, more dedicated equipment was developed, especially by Medtronic, where the patient here is undergoing pacing and you use the analyzer and also the EP system to try to localize exactly where the His bundle is so that you can locate it and then screw the lead with a special lead. And once this is done, you will be able to see either selective capture of the His bundle, non-selective, which means that there is His bundle capture and surrounding myocardial capture, or pure myocardial capture where there is no evidence of His bundle capture. Next example of a patient that we are doing His bundle pacing, and you can see here very nice His-Purkinje potential. You know that is the area where the His bundle is. And when you pace this patient, you can see that there is non-selective His bundle capture, and then there is loss and only myocardial capture here. The early studies on His bundle pacing was also done by Zenon et al., but it was only when Vijay Raman subsequently in 2017 showed that there was reduction in heart failure, hospitalization, and death, that the His bundle pacing popularity increased. In one of the important papers from his group in 2015, they showed data that His bundle pacing was both safe and superior to right ventricular pacing in routine clinical practice, and showing that the outcome of these patients, such as mortality, was definitely improved. Again, another study from China now showed that in patients with heart failure, upgrading to His bundle pacing resulted in the improvement of patients with pacing-induced cardiomyopathy or who were BIV non-responders. And in the more recent study, you can see that conduction system pacing versus RV pacing, all the endpoint of death, hospitalization, or upgrade to biventricular pacing was reduced, especially in the patients who had ventricular pacing more than 20%. In general, the success rate of His bundle pacing is as much as anywhere from 50 to 95%, of course, depending on the expertise of the person who is doing it. There are, however, limitations of His bundle pacing. First of all, is that there is still limited tools. The anatomy can be difficult, especially if the heart is very abnormal dilated. Hence, one could say that as much as 10% of the time, there can be failure in the implant. Another problem is that the thresholds may be high, and this may come on later And again, as much as about 10% may need a revision. Because of the higher thresholds needed, battery longevity is reduced, sensing issues may be there because of smaller R wave, or there may be potential P wave oversensing. You may also fail to correct the bundle branch block, or you may need high output in order to correct the bundle branch block, and this again may result in battery depletion. Complications may occur, such as dislodgement. Heart block may occur during the implant if you are not careful. Hence, the development of left bundle branch block, and credit must be given to Dr. Huang, who first described it in the paper published in the Canadian Journal of Cardiology in 2017, where he could not do his bundle pacing, moved it a little bit more ventricular, and did a left bundle branch pacing. So you can see here, for example, a patient where we have put a his bundle lead and a left bundle area pacing. This is a little bit more ventricular, and in the LAO, you can see it is slightly lower than in the his bundle area. The main thing when you're doing his bundle pacing is you need to look at the ECG changes in V1 and in V6. In V1, as you screw the lead in, you can see that initially, when you're on the right side of the septum, there is a W pattern. And as you screw the lead in, you can see that there is a development of a terminal R wave. And then the right bundle morphology comes when you are around the area of the left bundle. And similarly, in the left, in V5 and V6, there is a LV activation time. You will see that as you are nearer and nearer the left bundle, the LV activation time shortens to about 80 milliseconds or less. There's a patient where you can see here, we are doing the, after you screw it in, you can see that there is a clear, nice left bundle branch potential. Again, there is a selective and non-selective left bundle branch pacing. In selective bundle branch pacing, the QRS morphology shows the typical right bundle branch delay with an RSR pattern. There is an intrinsic isoelectric interval. This, of course, not that easy to see. And the interval between the pacing spike is identical to that between the left bundle potential to the QRS onset. In non-selective, you will see that there is no isoelectric area, and there is local myocardial capture that can be seen. For example, this is one of our patients here. You can see this is having a patient with non-selective and then going to selective his bundle capture. QRS is actually very narrow. LV activation time is very short. The advantage of left bundle branch pacing is that there is a larger area to capture, so it's easier to locate and succeed. Because you're screwing in deep into the septum, is much more stable and the thresholds are usually excellent. Sensing is also much better, and it is more likely to correct a left bundle branch block than his bundle pacing. The risk for infrahisian block is not likely, and of course it is safe for patients who have post-AV nodal ablation. There are, of course, slight disadvantages. It is more difficult if the septum is scarred or hypertrophic. You may have difficulty to screw it in. There is a risk that if you screw too much, there may be septal perforation, or there may be damage to a septal artery. Most important, of course, there is not enough long-term study at this point in time, but I think that the studies are likely to show that left bundle branch pacing is the way for us to go. Success rate is generally about 80 to 90%, so definitely much higher than that of his bundle pacing. And the need for lead revision is generally only about 1 to maybe 2% at most. So again, there have been studies on left bundle branch pacing that have shown consistently that it is a good alternative to his bundle pacing. So patients are now being done with left bundle branch pacing, for example, in patients who have heart failure. These are CRT indicated patients. Zhang et al. From China showed that left bundle branch correction was possible, and there was also improvement in the heart function post-pacing. So in this study by, again, Vijayaraman, again, he showed that the QRS duration was improved, the NYHA was improved, the LV ejection fraction was improved in patients with left bundle branch area pacing. So the indications for conduction system pacing actually includes anyone who may need ventricular pacing for more than 20%. For example, even patients with sick sinus syndrome with prolonged PR interval, of course, the patients with AV block, patients with pacing-induced cardiomyopathy, heart failure patients with bundle branch block, and in CRT non-responder patients. Thus, you can see that in the 2018 guidelines, for example, patients who need a dual chamber pacing and is expected to have ventricular pacing of more than 40%, then his bundle pacing can be considered, and it is considered to be a class 2A indication if it is more than 40% likely to have ventricular pacing. In the latest ESC 2021 guidelines, you can see that in CRT candidates in whom the coronary sinus lead implantation is unsuccessful, his bundle pacing is considered a treatment option and it is a 2A indication. Also, his bundle pacing can be considered an alternative to right ventricular pacing in patients of AV block and LVEF more than 40% if the ventricular pacing is more than 20%, and it is a 2B indication. Understandably, because there are no long-term studies, there is no recommendation at this point for left bundle branch area pacing, but it is stated that it is likely that once the data from randomized studies are published, that this will be in the guidelines very soon. Thus, in conclusion, conduction system pacing preserves the intrinsic conduction and maintains synchrony, thus reducing the likelihood for heart failure. Current tools are likely to improve, making it more easy to implant, and there's growing evidence for its effectiveness that patients who require ventricular pacing anywhere from 20% or more, that conduction system pacing should be the treatment of choice. And currently, there are several randomized trials being done, and this role is likely to be confirmed in the near future. Thank you very much for your attention.
Thank you so much, Dr. Songtio, for having a very good and very interesting presentation. Yeah.
Thank you.
Next, I would like to invite Dr. Sofian Johar from Brunei to have a presentation topics that needs a pacemaker, current status and future perspective. Please.
Good morning. Thank you very much for the kind invitation. My role here today is to discuss leadless pacing. Where are we? So leadless pacemakers have been around a while, and this is an example of a nuclear-powered intracardiac pacemaker which was published in the 1970s, put into a dog, which demonstrated the proof of concept. Nowadays, where are we? We currently only have one device commercially available. That's a micro device from Medtronic here in the middle with a passive fixation mechanism. There was a previous device called Nanostim from St. Jude and now Abbott, but this has been withdrawn from the market, and this had an active fixation mechanism. So in terms of the micro pacemaker, which is what we'll concentrate on now, the volume is 0.8 centimeter cube and uses self-expanding nitinol tines as a passive fixation mechanism. It is a VVI or single chamber pacemaker, which is important in our discussions later, and uses an accelerometer for a rate response sensor, and we'll discuss how this might be taken advantage of to provide dual chamber sensing capability. The battery is a lithium silver vanadium oxide and carbon monofluoride battery. And device longevity is thought to be around 10 years. It uses telemetry as it uses radio frequency as a telemetry option, and it is possible to retrieve it using the docking button, and we'll see that later. So the early study which was published in 2015 demonstrating early performance of this device was very favorable. It used 140 patients, 60.7% male, 77 years old. The mean number of attempts fairly high at 2 plus minus 2, and maximum attempts were 18. So first attempt success rates were fairly good at 59%, and the mean implant time was 37. That's really come down. So the average fluoroscopy time was 9 minutes, with one patient having 18 attempts, and this resulted in a pericardial effusion. So if you look here, 107 of the 140 devices were placed at the RV apex, and then 32 or 24% were placed at the anterior septum, mid-septum RV outflow tract. I think generally we think the best position is around here, not too far from the tricuspid, not too far from the tricuspid valve, but still some distance away, and away from the thin-walled RV apex. So this was the pivotal study that resulted in approval, looking at patients in a multi-center study with the micro device. There were 725 attempted implantations, and the success rate was 92.2%. Most of these were successfully implanted in the RV apex, with less in the RV septum and mid-septum. You can see here the introducer in and out time was much less, at only about 35 minutes. Delivery system in and out time was also 23 minutes, and total fluoroscopy time was 8.9 minutes. So this has become a fairly quick procedure. If you look at the major complication rate, you can see here that the major complication rate compared to historical control with transvenous system was much less, with red being the transcatheter pacemaker at just around 4%, and historical controls being around about 7%. So this is very favorable at 1 year compared to historical control. In terms of complication rates, we know that this is a large bore sheath, and we're placing it sometimes near the RV apex. So there's always a risk of pericardial tamponade from cardiac perforation. And there was a 1.6 rate of traumatic cardiac injury, but no evidence of late dislodgements. In terms of how it performs after implant, basically because the device is more or less semi-permanent, it's quite hard to retrieve on a routine basis. We're very interested to know how reliable the sensing and pacing parameters are with implantation. So you can see here that the threshold is fairly stable at 0.24 milliseconds over a period of 1.5 years. The impedance is stable, and the sensing is also very stable. So it's very gratifying to see that once you implant this device, in general, the parameters stay stable. If you look at a more recent registry, looking at the implantation of these devices, you can see here that in the real world, the complication rate is still very good. At around 2.7% at 1 year, compared to a reference data set of 7.6% with conventional devices. So again, very favorable. It seems to be even a little bit better than the initial trial that demonstrated safety. So looking at this registry, in general, they were elderly patients with a BMI of around 27.6. If you look at reasons why, there are some patients in this registry who had cardiac injury, and if you look at the reasons why, you can see here that they might have had a lower BMI, presence of COPD and chronic lung disease. So this kind of tells you a little bit that these patients might be slightly higher risk of perforation, therefore something to take note of when considering these devices. So this is how we implant a micro. So this is the sheath with the is advanced into the IVC, and then the delivery system with a micro attached to it is placed in the right atrium. It is deflected down towards the into cross-site tricuspid valve into the right atrium. And what we're looking for, and then we place it at the RV apical septum in this case, and then we inject some contrast through the delivery system in order to localize the position. You can see here that the device is placed in the apical septum in a heavily trabeculated area, and this is a good site to consider implantation. So once we implant the device, we do a fixation check where we actually pull on the device to actually see if there's engagement. In general, we need 2 tines opposite each other to confirm adequate fixation, ideally 3 or 4. And you can see here that with pulling, the top and bottom tines splay, indicating good fixation. In this view, at least 2 tines can be seen, and you may need multiple fluoroscopic projections in order to see the other tines. So we implanted our first device on the 23rd of January 2015, and we have described our initial experience with device in a publication where we implanted around 9 devices with satisfactory pacing thresholds. We did use ProGlide and Z sutures for hemostasis, and our implant R-wave and thresholds were fairly good. Most of the devices were placed on the apical septum. We've since implanted more, but this describes our initial experience. So the fluoro time was similar to the published report, 8.9 minutes, procedure time 66 minutes, and the threshold and R-wave were very good with a mean of 1.2 deployments. And again, R-wave at R-wave sensing and in follow-up were very stable and satisfactory. It is possible to do RV angiography as part of the microimplant. So this is an example of the first one we did, where we did rotational RV angiography to try and help us tell where the septum was. One of the concern is if you have a micro in the heart, it's not, the device is theoretically encapsulated by fibrous tissue after a few months. So there's some concern about whether we should extract it or place a new one. In general, studies have shown that you can implant more than 1 micro, perhaps room for about 3 in the right ventricle. And this is an example of a first report of a second micro after premature battery depletion because of a high threshold. If you look at a study looking at how many micros can be placed, this was an example from 2016 demonstrating that at least 3 micros possibly could be placed in the heart without affecting tricuspid valve function or other parameters of RV function. What we do know is that the micro itself can be extracted after implantation for a period of time, and this is the first example of a chronically implanted micro which is retrieved. Essentially, you can see here that they used a micro delivery sheath. One of the problems with retrieving it is that the micro sheath only comes in as part of a micro delivery set. Therefore, this was as part of another procedure, implantation procedure. So these micro sheaths to actually snare the previous micro, and it was pulled out through the delivery sheath without implantation, without any incident. So you can actually do concomitant procedures with a micro procedure. And in this case, we implanted a left atrial appendage occluded device and called a Watchman and a leadless pacing system through the same venous in a single sitting. You can see here on the right-hand side, a Watchman device being implanted under TE guidance. This is the Watchman delivery sheath, and there's a tug test to check for device stability, and that's fine. So this is an RV angiogram done at the time, just before the time of the microimplantation, just to see what the septum looked like. And we placed a micro here towards the RV apex. So other concomitant procedures that have been tried are leadless pacemaker and AV nodal ablation, which is attractive for elderly patients for a single procedure. And of course, patients who've had a history of infection, a leadless pacemaker and the subcutaneous ICD is a potentially attractive option to reduce the risk of an infection from someone who's had previous endocarditis. There are certain advantages and disadvantages of the approach, which we'll go into later. Perhaps the most, perhaps the biggest advance in technology has been the micro AV, which is basically a VDD system which is basically a system which uses the micro's accelerometer to sense atrial activity through the accelerometer. So it only paces V but senses the atrium and ventricle. So VDD. So the initial feasibility results were published in 2018. And what this does is takes advantage of the accelerometer signal in order to actually tell the pacemaker as to what is occurring in the cardiac cycle. So what you can see here is the A1 signal, which is isovolumic contraction and mitral and tricuspid valve closure. The A2 signal is aortic and pulmonary valve closure. And what's important for us is the A3 and A4 signal. A3 represents the end of, represents passive ventricular filling and the end of ventricular systole. And the A4 signal represents A4 contraction. So if you can time this with the end of ventricular time activation of the micro with ventricular systole and time it as well with atrial contraction and know when atrial contraction is, you can actually time the pacing spike to be just after atrial contraction, therefore giving you synchronous atrial and ventricular activation. So looking at the A3 and A4 intervals is critical to actually sensing the atrial activity properly and timing it well in order to give ventricular contraction. So if you look at the signal below, the device uses a rectified signal, and you can see here what the device sees in terms of signal. So based on the electromechanical delay between the electrical P wave and the A4 signal, the A4V pace was typically programmed to 10 milliseconds. The algorithm also incorporates a rate smoothing feature designed to maintain AV synchrony during intermittent A4 undersensing. And if an atrial contraction was not detected, the ventricular pace was delivered at a programmable rate smooth interval, typically about 100 milliseconds longer than the median RR interval. So this algorithm as well is not, doesn't work so well at higher heart rates because the A3 and A4 tends to merge and becomes an A7 signal. And therefore at higher heart rates above 105 beats per minute, the device will automatically switch to a VVI mode from a tracking mode. So this was the pivotal study looking at the Marvel 2 study, looking at the micro AV system. Again, we see here the A3 and A4 signals, which are programmable. Usually the A3 window, as in the length of the A3 window, can be adjusted, done automatically or manual, and the height of the AV threshold can be adjusted. If it's too high, then it will undersense atrial activation. If it's too low, then it may be subject to noise. So you need a sweet spot really to actually detect atrial activity reliably. You can see here, again, the diagrammatic representation of what you see. So so what you have on the channel here is an AM channel, which is a new marker, the atrial mechanical channel, which indicates atrial mechanical contraction. You can see here that when the device sees this signal, it has sensed atrial mechanical contraction and followed by a V pace. You can see here a VE signal, which is ventricular end, which is the end of the A1, A3 signal, and A4 here. You can see here atrial systole, which corresponds to A wave, and A4 threshold is set at level to be able to detect A4, the A4 signal. So here's an example of the tracing you can see. You can see that sinus rhythm. You can see a dropped ventricular beat here. The device mode switches to the pacing mode. And what you can see here is that VDD pacing mode. And what you can see here is that it's starting to sense atrial activity and provides VDD pacing. So you can see here, for example, at lower heart rates, the sinus rate here and the pacing rate and the ventricular pacing rate, sensor rate here. So you can see here that at lower heart rates, there seems to be a reasonable amount of AV synchrony, but at higher heart rates, the device switches to VDIR mode, and basically you lose AV synchrony. But then as you slow down again, the device detects this, and you go back to VDD pacing. You can see here what I discussed earlier, what happens at higher heart rates. The A3 and A4 signal becomes merged, becomes an A7 signal, and this is why the device has switched to a non-tracking mode. So that was a trial. What about in real life? This was published recently last year, and they did say that in this is MAM is a manual atrial mechanical test, and it looks as though that in this study cohort, majority of which had an AV block, the median total AV synchrony was 83%, which is quite favorable, and 64% had total 7% AV synchrony. But what was interesting is that despite optimization at discharge, 70% at the follow-up required optimization of program atrial sensing parameters. And in the second follow-up, after the first follow-up, the mean tracking index was 54%, and the median total AV synchrony was 93%, and 83% had total 7% AV synchrony. So this is fairly good. However, they do note in patients with a high percentage pacing burden, the AV synchrony was not as high. So this does tell us that there's more room in the to optimize the algorithm to try and promote AV synchrony. So suggested troubleshooting steps to micro AV tracking. We need to ensure the surface ECG has a clear P wave. We need to correlate A1 and A4 with the surface ECG. The accelerometer can use 3 different sensing vectors. And so we can adjust and change the different sensing vector if the A4 signal is of small amplitude. Do a manual atrial mechanical test in VDI mode and VDD mode in order to see what the device is seeing without interference from pacing or the automatic algorithms. And then we can either adjust A4 threshold, adjusting the end of the A3 window. We can adjust the A3 threshold and adjusting post-ventricular atrial blanking period, which can help with the device sensing the atrial activity and tracking properly. So other factors that might influence device choice, but micro AV versus a transvenous system. If this is quite useful in patients with end-stage renal failure due to risk of device infection. Often these patients have upper extremity venous stenosis, if they have prior CIED infection, and if you want to avoid transvenous lead, a micro AV might be useful in someone with sinus rhythm. Previously, the standard micro single chamber pacemaker is generally used in patients with atrial fibrillation and perhaps elderly patients with complete heart block, where AV synchrony is not important in order to reduce the risk of pacemaker syndrome. So when you might choose a transvenous system is when you have a fast baseline sinus rate of an AV system. As you can see, the device has issues tracking high heart rates. So this will be an issue with exercise. You cannot guarantee 100% AV synchrony. So if you want 100% AV synchrony or near 100% AV synchrony, you will need a standard dual chamber device. And of course, sick sinus syndrome, but this device does not pace the atria, so it does not provide atrial rate support. So the potential issues when the device is ventricular is fast to be aware of. When the ventricular rate is faster than 40 beats per minute, it'll switch to VVI plus 40 mode. And with high sinus rates, reprogram might be necessary, and watch for oversensing and undersensing of the A4 signal. So what's the future? We are still waiting for a leadless atrial pacemaker. The company is testing various fixation mechanisms, but that's still a way off, I understand. And of course, the holy grail is to have an implantable atrial and ventricular pacemaker to allow dual chamber pacing and sensing. And this system would hopefully also allow communication between the two devices. Again, we'll wait and see. Problems with atrial fixation include the risk of perforation because the atrium has a thinner wall. What about extraction? This is a micro, our experience where we implanted a micro where only one time was successfully lodged, and you can see that here. Unfortunately, the device was hypermobile afterwards with a high threshold and poor sensing. We therefore snared it. We snared the body first and then managed to snare the button. And then we use a deflectable sheath to bring it into the IVC, but it dislodged again. So we caught the body again. And we're able to retrieve the device. So what about pairing it with a dedicated subcutaneous ICD? Boston Scientific is coming out with their Empower microliters device, which will communicate with the subcut ICD system. This is still in the process of study, and there's a randomized control trial which will come up, which we hope will start and effectively address this issue. An interesting development is the YCRT system, which is a wireless LV lead, which is placed in the left ventricle and powered by transmission from a dedicated ultrasound transmitter, which is placed separately, which is wireless, which can work with another ICD system. So this will allow biventricular pacing if an LV lead is not an option. So the device is placed via the retrograde approach in the LV. This is the receiver pacing electrode, and then a transmitter is placed adjacent to it and on the surface just under the skin. And this should hopefully be able to communicate with the device and provide power for LV stimulation. So in a study and initial experience, you can see here that there's an improvement in cardiac parameters, including left ventricular end-diastolic volume and ventricular systolic volume. QRS duration does narrow, and ejection fraction does improve at 6 months. So we're still waiting for more news, and this remains a promising therapy. So a Swiss approach is also very interesting, where they've done experiments to show that you can harvest the body's own energy in order to generate electrical impulses to actually pace the heart, and this perhaps might be the future. There are other biological pacemakers which are also in development, and again, we're waiting to see where this goes. So to conclude, leadless pacemakers are an option in selected patients. This is associated with fewer complications related to the lead, although perhaps there's a slightly higher risk of ventricular perforation tamponade, which should be borne in mind. The advantages when it comes to venous access issues are very attractive, but long-term, we're sometimes not sure what to do about these devices. Do we extract, do we replace? In the vast majority, we should probably just put a new device in to reduce the risk of the procedure. Concomitant procedures are possible, and the biggest recent advance so far is the micro AV system. And we await data from the combination of a dedicated subcutaneous ICD and the pacemaker system. The YCRT system for LV pacing is interesting. However, it's unclear where this fits in with the current excitement with conduction system pacing, which you'll have heard about, as this is now increasingly seen as a bailout for patients who cannot have conventional CRT, and might eventually be even a preferred option for selected patients, and this will be tested in randomized trials, we hope, in the future. And with that, thank you very much.
Okay, thank you, Dr. Johan. Yeah, it's nice to see you after 2 years ago. And then now we can open for the Q&A, and we hope the first speaker online. Yeah, and then we got one question from the online viewer. I think this question to go to the Dr. Trần Thống. The question is is AV-Sense trigger CRT you recommend for CRTP, and can you explain why is it better? And Dr. Trần Thống, please.
Well, that's a very good question. Let me say that, right, yeah, I earlier was working only on the, what I call the semi-intrinsic, but now with the latest result, I believe the, what I call the AV-Sense trigger CRT is really the way to go, because first of all, it's physiologic because it's using the RV propagation that is controlled by the autonomic nervous system. So it will provide a feedback on what the body would need. And the other thing is that with the AV-Sense trigger, you have a synchronized LV pacing, which has been a problem that a lot of people have not been able to solve. You know, how do you, if you have a good response from the RV, how do you synchronize it with the LV? And the function, the AV-Sense trigger, allows you to synchronize the LV. There's a small, there's about a 20 milliseconds delay between the AV-Sense and the LV pace, but that's typically, it's a fairly small compared with if you have left bundle branch block. So I think that, and I have done some study which looks like it depends on what the shape of the depolarization is. And it may not be that much of a difference between the two depolarization of the left and right side. So I think that's really the way to go. And it solves your problem that you have a physiologic response, and two, you have synchronization between the two ventricles. Thank you.
Okay, and then in fact that when I do some case, when I saw, that when we do only the NV pacing, it's the QS, so that's so wide when compared with the the BIV. And then sometimes that we like the BIV more than the NV because that's beyond the the QS complex, and then you think that yeah, in some case I think that it can improve, maybe it's got the effect, but that the case of the unstable, you think that the NV this thing can do like the BIV or not?
I think that we have been too conditioned to look for the neo QS. It doesn't matter how the width of the QS you get, because what matters is when the two ventricle contracts. And we can, we've done some study. Essentially, we've been trying to optimize the LV only, and we've looked at the two wavefront, the one. And you can do that. We've been doing that on the programmer, so we limited to D1, D2, and D3. And we found that actually on the D2 leads, if you start with the LV delay being very small, you can see the wavefront from the LV moving across. And when you get, and whereas the passive system point, the deposition of the RV is fixed because it's a propagation from the atrium. So you can see at some point, you can see the reposition of the LV it's right in the middle of the deposition of the RV. And if you use the principle that you have the peak, the largest deflection of the deposition is an indication that you have that you have the most mass contracting, then we found that we can minimize, we can optimize when it happens, but it has nothing to do with how narrow the QRS width is. That is a concept that people have done because they haven't really looked at what's happening. So they say that, well, it's narrow and it's good, but I don't think that's necessary that it has to be narrow. No, you have to go.
Do you have a comment about it? Dr. Teo?
Yes, hello.
Yeah.
Sorry, you want me to comment on?
Yeah, comment about the NV pacing.
I think, to a certain extent, I like to add the comment that the conduction system pacing gives us an additional tool to use the intrinsic conduction. And then you're right that sometimes because there may be a lot of intraventricular conduction delay, there may be infrahesian delay, even your conduction system pacing may not be optimum. That's why people are also talking about both synchronizing conduction system pacing and LV pacing. And I understand the concept that, we cannot just look at the QRS alone. I think we may have to go back to the echoes or to the other form of assessment to look at how good the ventricular conduction. But I guess a cheap and simple way is still to look at the ECG. I mean, if you get narrowing of ECG, it's probably going to be good, but it's not 100%. That's my comment.
Okay. Thank you. And then another question, maybe I to come to the Dr. Thomas Bump. What the role of the CRT and AV node ablation in the patient with the heart failure and the atrial fibrillation? Yeah, AFib. And then Dr. Bump.
That was covered in the BLOCK-HF trial, where some of those patients in BLOCK-HF from 2013 were exactly this kind of patient where they were randomized. If they had ablation of the AV junction and they had atrial fibrillation, then they were randomized to have either right ventricular pacing or biventricular pacing, and the patients who got biventricular pacing did much better. And in BLOCK-HF they went all the way up to they allowed the use of the CRT in ejection fractions of up to 50%. So that was one of the cases where they used CRT in patients with ejection fractions up to 50% and got benefit from that in the patient. So I think the role of CRT in those kind of patients is high. Either that, or you can see how conduction system pacing could be very good also. Either his bundle or left bundle branch block pacing could be good also. I expected that it will be good and it will have a role there also.
Okay, and then maybe this question go to my friend Zoha. And then when we set the leadness pacemaker out of the right ventricular aspect, is there any different of effect when we set up it the other position? And then Dr. Zoha, please.
Yeah, I mean, basically, I think probably the easiest position are the apex, but it's actually quite close to thin-walled right ventricle, the free wall in that situation. So it does increase the risk of perforation. So in terms of the preferred location now, it's probably more mid to apical septum. And you don't also want it too close to the tricuspid valve for possible interaction. You want to avoid the RVOT because it's not very heavily trabeculated. So the purchase of the device onto the myocardium is not as good. So effectively, in all honesty, it is quite tough to define precisely exactly where your device will fix to when you actually implant. You can really decide the height, but actually how close it is to the tricuspid valve is quite difficult to predict actually doing the procedure if you don't use any further imaging. In practice, though, there's usually quite a bit of distance. So, but theoretically, there's some potential interaction and to increase the risk of tricuspid regurgitation. But otherwise, in general, you will probably want to concentrate more on the actual implant parameters for long-term results. So in a cart which otherwise normal, you also want to avoid scar areas. You should aim for implant threshold less than 2 at least. And then hopefully this will be enough to give you a good long-term threshold because premature battery is a problem. If you actually have a high threshold and you're then faced with early reimplant or putting in a transvenous system.
Okay, and then I saw the case you extract the device out, and then very nice, you know. But in fact, that you think that how long we can do like that, and then I mean the time.
Well, obviously that occurred. It was probably a mistake on our part because we thought we had adequate fixation of the device. We cut the tether, but in fact we only had one time. So obviously the device had embolization to pulmonary artery, but we managed to snare it inside the right ventricle. So it's fairly acute. You see the published report was 29 months. Theoretically, in animal studies, the device should be fully encapsulated by around 3 months. But in humans, we don't know that for sure. I believe people have attempted extraction and been successful for longer periods. But we do not know what's going to happen 10 years down the line when we have this wave of microbes which may or may not be extracting. And we still need dedicated tools because currently the tools that we have are kind of like cobbled together from existing equipment. So that would be an issue. And I think that this is something that hopefully we should not face too often. The device is supposedly, according to observational data, more resistant to infection. There are only a handful of reported cases of infection which will require extraction. In all honesty, I think it is worth a try, but only for a good indication. So I think in general, we need the device.
Okay, and then maybe the topic of Dr. Trần Thống is not many questions, and then another question for the Trần Thống. Maybe I think that it's very nice question. Is there any comparison between the CRT only RV and only NV? Yeah, does the CRT only RV or only NV make sense?
Are you saying the comparison between biventricular and LV?
Is there any comparison between the CRT, only the RV, and only the NV?
There's some work on the LV only, and actually, you know, the biggest work is a work by Medtronic that was using the adaptive CRT, and the main advantage is the reduction in the AF because essentially you're reducing RV pacing. So LV, if you use the intrinsic conduction in the RV, you want to reduce AF. Okay, and what we're doing here is we're showing that not only that, but if you let the RV conduction and you use the RV conduction, you have a more physiological system. And the latest is the version is the RV sense trigger, which essentially use that. I hope I answered the question.
Okay. And then
I have one question for Dr. Tieu. Yeah. According to your opinions, in patient AV block with heart failure, do you prefer heat pacing or CRT?
Well, it depends on whether the patient has got very wide QRS. Definitely, if the patient has narrow QRS, CRT is out. If the patient has a little bit of a very typical left bundle branch block, then I may now probably go more for left bundle branch area pacing, because we know we have now quite good data. The QRS is very narrow. But if the patient has very wide QRS, lots of myocardial disease, then I think you must be prepared that you may have to do both a CRT, and I may just go for a conventional CRT because it is in the guideline, it is a class 1 indication. And if they don't respond, then put it in his CRT, or I may at this point in time, because I suspect that this patient may need both LV pacing and his bundle pacing. And if you want to avoid a procedure, it may be a bit more complicated, but instead of putting it in the RV apex, put in an LV lead and put in a left bundle area pacing at one time, as is being done for patients who do not respond to CRT. I think this is an evolving field. We need more data, but at this point in time, we have to do what we think is best for our patient.
Thank you so much.
Yeah, we got a very short question for Dr. Tieu. And then when we do the his bundle pacing, one thing I worry about the this lot of the lead, and then maybe you think that the left bundle pacing is better.
Yes, I have almost stopped doing his bundle pacing because it's difficult to predict. I mean, you can get a nice threshold and you can get relatively good R wave, and then a couple of months later, the threshold goes up. Of course, there are also some cases that have done very well and continue to have beautiful narrowed QRS, but left bundle branch pacing is much more stable. The only thing, it is not in the guidelines yet, but I think the future is probably going to be left bundle. And now I almost always do a left bundle pacing rather than his bundle.
Okay, thank you. And then now, please, Dr. Khánh, please can do the following.
This afternoon, this morning, we have 4 topics, very interesting topic. So far, pacemaker, especially pacemaker in heart failure, were always the hot topics in EP and cardiology. Yeah. And this morning we have 4 topics. I think all of you give for cardiologists in Vietnam so much of information, very good information for very interesting. Yeah. One topic from Dr. Thomas Bam from United States of America. One topic from Dr. Chen Tong from United States of America. One topic from Dr. Song Kyu from Singapore. One topic from Dr. Johan and Sufyan Johan from Brunei. Yeah. On behalf of meeting organization committee, we express our deep acknowledgement to all of you. Yeah. I hope see you again in next time.
Okay. Thank you.
Thank you all the friends, and then hope to see you again in the Vietnam when COVID is out. You know?
Okay.
Okay, nice to see all the guys. So we know that nothing changed for you.
Bye bye.
Especially
Yeah,
Dr. Teo. Yeah, you never changed in another 50 years ago.
Bye-bye.
Yeah, bye bye.
Take care.
Bye bye. Thank you so much. Yeah. Thank you so much from Dr. Bum. Yeah.
Oh, it's great to see you again. It's wonderful to see you.
I miss you so long time. Yeah.
Oh, and I would like to,
soon to see you. Yeah.
I would like that very much.
Yeah.
I would like that very much. Let me know when you're in America, or I will come to Vietnam and see you. I would like. I miss you very much.
I always remember you and your family. Yeah.
Oh, thank you.
Yeah.
Thank you. We remember you so fondly. It's great to see you.
Yeah. See you. Yeah.
Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách, nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021.
Good morning, everybody. My name is Ann Nguyen, and I am coming from Chicago in the United States, where it's 10 p.m. over here. I am so pleased to be invited to be the chairperson of this session. I think it's a very important session. It is pulmonary artery hypertension and heart failure. And the talks today really are expansive. They go from talking about AI modeling for ECGs to detect elevated pulmonary artery pressure to application of remote monitoring for pulmonary artery hypertension in the management of heart failure. And then our last two talks move on to more so the management of pulmonary hypertension, the first being the roles of vasodilators in pulmonary artery hypertension and heart failure management, and finally questioning the use of pulmonary denervation in the heart management of heart failure. And what's also interesting about the talks is also the speakers. I'm very excited to listen to perspectives from professionals all over and experts all over the world, including Taiwan, China, and Vietnam. And so again, welcome to this session. And we will start off with Dr. Yu-Feng Hu, his talk is the ECG model of artificial intelligence detects elevated pulmonary artery pressure. Dr. Yu-Feng is an associate professor at the School of Medicine in National Yang-Ming University in Taiwan. He is currently affiliated with the Taipei Veterans General Hospital and is extremely active in the cardiology societies in Asia as well as in Taiwan. And so with that, I will let Dr. Yu-Feng Hu start his talk.
Okay, thank you, Professor Ann's kind introduction. I really thank the committee to invite me to talk about my study. And this talk will be related to how to use the artificial intelligence EKG to automatically screen the patient with elevated pulmonary artery pressure. And we also link the data to the prognosis to see any impact on the clinical practice. So as we know, the pulmonary hypertension has been categorized in the 5 groups. And the one group is the primary pulmonary artery hypertension. And the other related to the, I think is more, the patient number is much more than the first group, is the related to left heart disease, lung disease. And the patient class 4 is chronic thromboembolism, and the rest of the is miscellaneous. So as we know, we spend lots of money on these diseases. It's more than $10 billion annually. So I think this is a critical issue to study and to think about how to detect those patients in early time and how to treat those patients. This is a Kaplan-Meier curve to show if the patient suffers from the elevated pulmonary artery pressure. As you know, if it's normal less than, for example, less than 40 and higher than 50, the mortality rate from 5-year Kaplan-Meier, it will increase from 20 to 78. So if the patient have a pulmonary artery pressure higher than 50, the 5-year mortality rate actually is much higher now than 50%. So this is a critical issue to identify and treat this patient group. Currently, much more study is limited on the pulmonary artery hypertension. This is a WHO group 1. And this, I have to say, there's the patient number is limited in this patient population. And most of the screening tests or some study algorithm is focused on this patient group. So, but they suffer from the low sensitivity. For example, use the NT-proBNP only 50%, pulmonary function test is 70%. The number of the tests can be combo as a algorithm, but still have some problem how to detect. And our study actually detect much more the patient group instead in addition to this patient group. We focus on more patient like the patient function, the group 2 or group 3. It's more general and the patient number is much more than this group. And we'll talk about when we try to screen the patient with elevated pulmonary artery pressure, we call it elevated PAP in the rest of talk. So this is a EKG, and this is the price that we need to spend when we do a study in Taiwan. So the EKG is much cheaper, but it's very rapid and is widely available, but the sensitivity is much lower. It's only 55%. Usually we use the echo to detect the pulmonary artery pressure. It's a standard. And this time, it's even in Taiwan, I think it's the same in the rest of the world. it's expert dependent. You need it's much more need more technique, and sometimes there's a longer waiting time. And rarely we use the CT or MRI. MRI is more expensive, so rarely used to detect pulmonary pressure. And the CT only can see the morphology or the chamber enlargement. You cannot detect the pressure directly. So that's the things we go through the current management, and we try to use the most cheaper and widely available tool to detect the patient with elevated PAP. As you know, the patient with elevated PAP or pulmonary hypertension, it's very commonly diagnosis has been delayed because in the beginning the symptom is minimal. So much more patients only feel the dyspnea on exertion or sometimes breathless, and then they can take 1 or 2 years or more to develop the symptom with edema or palpitation or heart stress. Then we will send to a hospital. You go through lots of study, then you can check. You can finally diagnose the pulmonary artery pressure has been elevated. So I think that that's a struggle process. If we can detect the patient, even as asymptomatic or minimal symptomatic in early time, that will be more important and try to treat the patient in early time. So that's the unmet clinical need. Currently, we prefer the echo, but compared to EKG, it's costly and it's time consuming, and you need to wait a longer time, and it's not suitable for screening tool. Especially sometimes you need some technician to detect the pulmonary artery pressure effectively. And the EKG criteria is relative sensitivity is much lower, so it's not satisfactory for the clinical detection tool. So we propose a solution is use the AI to improve the pulmonary artery pressure detection in the EKG, and that will be more rapid, widely available, and inexpensive. And I think it's good. It's not expert dependent. You don't need the very special technician or training technician to do the screening. So what we do, we actually use our EKG and the echo database. We detect a patient with a pulmonary artery pressure more than 50 millimeter. This is a high probability of pulmonary hypertension according to a guideline. And we search for the valid EKG and echo couple pair within 40 days. So that's around 40,000 patients, and we'll assign the 8-1-1 group. The 8 is a training state, the 1 is validation set, the other is a test set. Then we also recruit a patient from Japan. This is our external cohort, and to validate our AI model. And to be noted, in our hospital, we use the Philips EKG system, and in Japan, they use the Nihoko lens system. So it's not different, it's not in addition to the patient population, the differences. I think also the EKG system is also different. And I think you have to remind it, the EKG system difference will bring a lot of difference when we apply the AI model. We use those data and we try to organize and try to construct the CNN model. And this is a convolutional neural network. I will not go detail because most of the audience is a clinician. So I think that we just arrange a several block and a several layer and a 5 layer to detect all those patients and do the tenfold validation and try to detect the patient with elevated PAP or non-elevated PAP. So this is our result data. So in our test set from Taiwan, you will see our AUC can reach higher as 0.88. Sensitivity is around 81%, specificity around 80% or so. Also from the Japanese group, we also can reach the AUC around 0.88, but the sensitivity is green higher, specificity is lower. That's a problem because of the different EKG machine or the population. But the AUC is still satisfactory and much similar to our Taiwanese group. So that indicates even we use a different EKG machine or in a different patient population, ethnic, we also can reach a good diagnosis performance. This is the data that show we compare our data to the conventional EKG characteristic, like the P or pulmonary, right axis deviation, right heart hypertrophy, or RV strength, or RV mimic something. And you will see the sensitivity around 34%. But in our AI model, our sensitivity can reach to 80% to 90%. So that's a great improvement, around 40 to 50% sensitivity. And this diagnostics odds ratio, you must be interested whether this model can be applied in different patient groups. So we assign the patient as a different age group, different gender, hypertension, diabetes, heart failure, or stroke. Or the other, we will have rest like rheumatic disease, thromboembolism. And you will see the low is the diagnostic odds ratio is 5.8. The highest is the 23. So that's pretty good. So this is like the patient with a pre-severe NI, chronic kidney disease, chronic lung disease, pulmonary emboli, rheumatic disease. So the same thing, we can reach a similar or the good diagnostic odds ratio. So indicate this AI model can be applied in different patient groups. So let's talk about how this AI EKG can have an impact on the cardiovascular mortality and all-cause mortality. This is our data from Taiwan, and you will see during a 6-year follow-up, the patient with elevated PAP, they will have a cardiovascular mortality around 10%. And this is a 10% or 10-fold higher than those without elevated PAP. About the all-cause mortality, similar thing can be observed. So they indicate this EKG prediction model have clinical impact, and you can use this as a to detect a patient in early time, because most of those patients will develop cardiovascular mortality, and that's a significant number. So we should do something to treat the patient in early time, either in the patient with different population group. Another result has been validated in the Japanese population, we can observe the same impact on the cardiovascular mortality. So you must be concerned whether this is an independent parameter to predict. So we use all the underlying disease to do a multivariate analysis to see whether it's an independent predict for the cardiovascular mortality. As you know, the AI predicted elevated PAP is still one of is the highest hazard ratio, around 3.69 to predict the cardiovascular mortality. And when you combo combine all those scores with the underlying disease, the prediction ratio is even better. So this is another is about the all-cause mortality. You can see it's still an independent mortality predictor. So we are interested in whether we can expand. How can AI to detect those patients? Is there any rationale? So this is the AUC loss. We try to remove one by one of the older lead from the day 1 to V6 to see if we remove one lead, whether the AUC to detect the elevated pulmonary PAP will decrease the AUC. We observe actually V1 to V3 is the most important individual lead to detect the pulmonary artery pressure. And this is an example of the EKG. The patient without the EKG, the V1, 2, 3, that's an example like this. I think most of the audience will be very familiar with that. In the patient with elevated PAP, you can see that similarly, they can detect RV strength, the RBB mimic pattern, or the R is more dominant in a V1 to V3. So this is the one of the things you can see. Actually, AI detect a similar electrophysiology pattern in a patient with a right heart failure or right ventricular hypertrophy, hypertension, something like this. It's quite similar, but they see something more. Therefore, they can detect and have higher sensitivity than the conventional EKG pattern. So this is my conclusion. So the automated AI system from our study, they can detect the patient with pulmonary artery hypertension in early time. And this detection, the screening is associated with higher cardiovascular mortality or total mortality. So they indicate this tool is not either used for the screen, also can use as a prognosis parameter. The performance of this AI model has been robustly validated in a Japanese hospital. And we also use a different machine between these two countries. So that's very good. They indicate this AI model can be widely used in a different country and a different system. And that gives us a chance to try to treat or try to identify how those patients with the risk for the pulmonary artery hypertension or increase the cardiovascular mortality. Now we should do more and try to screen the cause, study the etiology, and try to treat those patients more aggressively to improve the chance of survival. So what do we change? We analyze this data in the Taiwanese the healthy data. So we are going to screen the patient, increase the sensitivity with 40-60%. So we will probably decrease in the Taiwanese patient, we will probably decrease the all-cause mortality by around 28% if we can successfully treat those patients in early time. It will translate to the total number is around 600,000 patients could be changed their treatment strategy. And moreover, because the EKG screening system is much cheaper, so you can, I think in the future, in our future study, we are going to use this to follow up patient. And I think this will significantly reduce the economic cost in our medical care. So this is our AI research team, and we do all the cooperation from our National Health Institute and Academia Seneca and the Taipei Venture Hospital and the doctor from Japan. So this more than 10 researchers, and they all devote their study and their effort on this study. Also our EKG member in our Taipei Venture Hospital. Okay, thank you very much for your attention. I welcome all the questions.
That was a great talk. I don't know if we have time for questions now. Let me see. Yeah, we do. We have time for 5 minutes of questions. How do we know if anyone's asking questions though? So I have a question for you. It seems like the formula that goes into the AI data analysis, I'm going to call it, is basically morphology, right? It was rhythm a part of that as well? Rate?
Oh yeah, the system you mentioned, if the patient has arrhythmia or their heart rate is different, is it right? So because we actually those all the information has been incorporated into the system. So indicate we put all the 12-lead 10-second the information into our AI system. Mm-hmm. So those information include not only the morphology, also the rate or the arrhythmia change during this 10-second 12-lead EKG information. So I think the AI system actually they think more than the morphology. They also take the rate or the arrhythmia into account. But unfortunately, because still a black box to interpret the result of the AI algorithm. So I see that's one of very important things to work on in the future. But in the present time, I only show you the change of the morphology. That's the common things the physician can understand. But I think the AI detect much more beyond that.
Mm. And you mentioned that V1 through V3 were the most important leads in terms of predicting mortality, correct?
Mm-hmm.
So I wonder if in your modeling, if rhythm or rate were things that were looked at in terms of mortality, and if those had a signal at all.
We actually, it's not only morphology to detect. That's the AI predict the elevated PAP. Mm-hmm. So it's not only V1 to V3 that will detect the mortality. This is the whole set will turn into the result of the AI prediction. But we take the V1 3 because to explain the result of the AI prediction. So it's kind of different. So with the AI system, actually, we just get a result because when we now in our hospital, when we get an EKG, And the AI system will inform you whether the patient have a pulmonary artery pressure increase or not. Then the doctor can take account into this information. And while we can go straight forward to try to practice like in the clinical scenario, because we clearly see the patient, if you have we detected the elevated PAP by the AI, they have really higher cardiovascular mortality and the total mortality in the future. So it gives us every reason to try to work out and screen the patient in the clinical clinics.
Sure. And I'll just end with this comment, but it is interesting when you think, I think this is a fascinating tool. And I do think it has the ability to save a lot of medical dollars, but I wonder how much of a time sink it would be on the people taking care of patients, because then there's more data for you to filter more patients that may have false positives, that you have to then have more nurses and doctors and staff to look at all these things. But I think that's what comes with big data and receiving a lot of information. And I think it will evolve over time, how we use this data in clinical practice. So with that, we'll move on to the next talk, I think. Thank you so much again.
Thank you.
So the next talk is I'm introducing myself. I am, again, my name is Ann Nguyen. I am a heart failure, advanced heart failure, cardiac transplant, mechanical circulatory support cardiologist at the University of Chicago. The majority of my practice is seeing patients that have advanced heart failure, and then a smaller percentage of them is heart failure, is heart transplant, and people who go on to have left ventricular assist devices. But the topic that I am speaking about today is application of remote monitoring of pulmonary artery pressure in heart failure management. It is a management modality that is used and leaned on significantly in the United States, and I'm very pleased to be able to present this data to you today. Hello, my name is Ann Nguyen, and I am an assistant professor of medicine at the University of Chicago Medicine. I specialize in heart failure, heart transplant, and mechanical circulatory support, and I'm very happy to be invited today to discuss the application of remote monitoring of pulmonary artery pressure in heart failure management. Here are my disclosures. I want to start off this talk by discussing why it's important to even talk about remote pulmonary artery pressure monitoring in heart failure management. Now, this is data from the United States that projected the epidemiology and future costs of heart failure from 2012 to 2030. And what they found was an increase in direct and indirect costs related to heart failure, with a projected total cost of $69.7 billion in 2030, and an increase in overall prevalence of heart failure. And I know that this is not data from Vietnam. However, there is some existing data on the prevalence of heart failure in Southeast Asia, which shows that the prevalence is similar to global values. Now, specifically in Vietnam, heart failure accounts for 15% of hospitalizations in Hanoi Hospital, with an 8% 30-day readmission rate. And this is increasing due to an increase in cardiovascular risk factors due to lifestyle changes in Vietnam. This poses a significant financial burden. The estimates of the average cost of a heart failure hospitalization in Vietnam is approximately $1,000 per patient, with the GDP per capita of being only $2,400. Now, given the trend that is being seen in Vietnam, mitigating the prevalence in hospitalizations for heart failure will be important for improving outcomes, quality of life, and keeping healthcare costs down. Now, we know what happens after a heart failure hospitalization. there is a readmission rate of 24% at 1 month after the hospitalization and at 50% at 6 months. This correlates with an increase in annual mortality rate of nearly double at 5 years. This data was replicated among 14,000 patients with repeated heart failure hospitalizations, showing that mortality increased with recurrent heart failure hospitalizations. And these number of repeated hospitalizations remained a strong predictor of mortality even after adjusting for other major risk factors, including age, sex, history of atrial fibrillation, and hypertension. What is important to note is that when patients present to us with symptoms of decompensation, their filling pressures have already started to increase nearly 30 days beforehand. And so the combination of everything I've presented to you so far shows that the application of PA pressure remote monitoring is crucial for the management of heart failure patients. Remote monitoring has clearly been an important arena in the management of heart failure and is not novel. In 2010, the TELA-HF trial evaluated nurse-driven telephone support for recently hospitalized heart failure patients to collect weights and symptoms over the phone. What was found was that telemonitoring did not improve any outcomes. The BEAT-HF trial randomized patients to an intervention or standard of care arm, with the intervention arm being health coach telephone calls and telemonitoring using equipment to collect data on blood pressure, heart rate, symptoms, and weight. The intervention arm ultimately did not reduce 180-day readmission rates. And finally, the InTime trial randomized 700 patients with chronic NYHA class 2 to 3 heart failure symptoms who had an ICD or CRTD to standard of care versus standard of care along with telemonitoring using intrathoracic impedance that can be determined off of these devices. The intervention arm had a significantly improved outcome with a composite endpoint driven by improvement in mortality rate. A fundamental shift in remote monitoring actually began with the advent of devices that directly and wirelessly measure PA pressures. This concept started in the 1980s with a Chronicle device that was deployed in the right ventricular outflow tract. It showed a clear signal of increased PA pressures at least 4 days prior to hospitalization. However, it did not meet its primary endpoint in the COMPASS-HF trial, likely due to underpowering. The HeartPod sensor was a left atrial pressure sensor implanted transeptally and was evaluated in the laptop heart failure trial. Study enrollment was stopped prematurely in this trial due to complications involving the transeptal puncture. However, in the patients who did complete the trial, there was a reduction in heart failure hospitalizations by an astounding 41%. Now we will get into the CardioMEMS device, which is currently what is used for PA monitoring. The device has a coil and pressure-sensitive capacitor. The coil and capacitor form an electrical circuit which resonates at a specific frequency and pressure applied to the sensor causes deflections in the pressure-sensitive surface, which then results in a characteristic shift in resonant frequency. The PA pressure sensor is implanted with a right heart catheterization, mostly via a femoral vein approach. However, there are some centers that are doing it through the neck. The target location for the sensor is the left pulmonary artery, and the mean sensor implant time after completion of the right heart catheterization is approximately 7 minutes, and this is from the CHAMPION clinical trial data. The CardioMEMS heart failure system is made up of the PA pressure sensor itself, an external electronic measurement system, and the heart failure website. Patients are instructed to take daily pressure readings from home using the external electronics measurement system. The information is transmitted from the electronic system to the website and is immediately available to clinicians for review. Transmitted information consists of systolic, diastolic, and mean pressure measurements and trend information and the waveforms. The website and the database are a key part of the system. It is very intuitive, very visual, allows trend-based management. And in this diagram, you can see that the red line is the systolic pressure, the green is the diastolic, and the blue is the mean. And here you can see that the trend lines can be generated, as well as discrete information. FDA approval for the CardioMEMS device was obtained based on the CHAMPION trial data. This randomized multi-center trial enrolled NYHA class 3 heart failure patients with any ejection fraction who have had a heart failure hospitalization in the prior year. All patients had a device implanted, and the intervention arm had daily measurements of PA pressures in addition to standard of care versus standard of care alone, which was the control arm. The intervention arm showed a 37% reduction in heart failure hospitalizations at 1 year. And these results extended beyond the initial trial, with 33% reduction in heart failure hospitalization in the randomized access protocol, and a 48% reduction in the open access protocol. And not only were there sustained results, but the results have been replicated in the real world. In this retrospective data by Desai et al., Medicare patients were evaluated during the period after FDA approval of the device. Medicare and Medicaid claims data demonstrated a 55% reduction in cumulative heart failure hospitalizations during the 6 months after CardioMEMS implantation compared to the 6 months prior. Now, what I've showed you so far is retrospective data. The real world results were even replicated in a prospective fashion. In this study, 1,200 patients enrolled across 104 US sites showed that daily adherence with the MEMS device was 76% and PA pressures declined significantly. The rate of heart failure hospitalization was reduced 57% at 1 year compared with the year prior to implantation. And the results were consistent across multiple predefined subgroups, including by left ventricular ejection fraction subgroup. The effects of the CardioMEMS system was not just reduction in heart failure hospitalization. Subsequent studies have found that with the remote monitoring of PA pressures, there are greater medication changes that are made compared to the control group. And what that leads to is a greater achievement in intensification of guideline-directed medical therapy. At 6 months, the treatment group achieved higher doses of guideline-directed medical therapy compared to the control group, which had no significant change at 6 months. I want to now go into the use of the CardioMEMS device in more specific populations. This study evaluated the subset of patients in the original CHAMPION cohort that had an ejection fraction of greater than 40%, which comprised of 22% of the entire cohort. There was nearly equal randomization in this subgroup to the treatment and control arms, and the primary endpoint of heart failure hospitalization at over 6 months was 46% lower in the treatment group compared to the control. And after an average of 17.6 months of blinded follow-up, the hospitalization rate was even lower at 50%. And in response to the PA pressure information, more changes were made in diuretic and vasodilator therapies in the treatment group. Recently, the effects of the CardioMEMS implantation was shown to not be sex-specific. This study evaluated six sex differences in the post-approval study that comprised 1,200 patients, of which 38% were women. There were similar reductions in PA pressure from baseline to 12 months in both men and women for the whole cohort, as well as for subgroups of HFpEF as well as HFrEF. Both sexes had significant decreases in heart failure hospitalization over 12 months, with no significant differences in the change in heart failure hospitalization between men and women or all-cause mortality at 1 year. I do want to speak about the GUIDE-HF trial that was recently published and was much anticipated. Now remember, the original CHAMPION trial enrolled patients that had NYHA class 3 symptoms, and the Heart Failure and Cardiology Society has been waiting to see if this extended to patients with more mild symptoms of heart failure. And so the GUIDE-HF trial randomized patients that had NYHA class 2 heart failure. 1,000 patients were successfully implanted between March of 2018 to December of 2019, as you know, was in the middle of the pandemic. And a pre-specified COVID-19 sensitivity analysis using a time-dependent variable to compare events before the pandemic and during the pandemic suggested a treatment interaction due to a change in the primary endpoint rate during the pandemic phase of the trial. And so this warranted a pre-COVID-19 impact analysis. What was found was that in the overall analysis, the cumulative incidence of heart failure events was not reduced by hemodynamic guided management. However, in the pre-COVID-19 analysis, there was a significant decrease in heart failure hospitalizations. Several factors could explain the considerable loss of benefit with hemodynamic guided management during the COVID-19 pandemic, including potentially improved patient compliance with medications and diet, reduced respiratory infections as everybody was quarantining at home, alterations in healthcare provider behavior, and potentially changes in disease progression due to COVID-19, and other as yet unknown effects of a worldwide pandemic. What about CardioMEMS in patients who have COPD? This study took the subgroup of patients in the original CHAMPION cohort, and in that large in the large cohort of the CHAMPION trial, 187 patients met the criteria of COPD. And in this subgroup, the treatment group had a 41% reduction in heart failure hospitalizations and an astounding 62% reduction in respiratory hospitalization rates. And what is proposed is that maybe the avoidance of volume overload in these patients can decrease the risk for pulmonary vascular stress, thus also preventing respiratory hospitalizations in addition to reducing heart failure hospitalizations. Now, this study similarly evaluated a subgroup of patients who had pulmonary hypertension in the original CHAMPION trial cohort. Specifically, these are patients that had group 2 pulmonary hypertension, which is due to left heart disease. There were 59% of patients who had group 2 PH, and overall, these patients had higher heart failure hospitalization rates than non-PH patients. In this subgroup of patients, the treatment group had a significant reduction in heart failure hospitalizations with a hazard ratio of 0.64. In the study on the right, 26 patients with pulmonary arterial hypertension and NYHA class 3 to 4 right-sided heart failure were implanted with a CardioMEMS device. What they found was that the device was used safely with no device-related adverse events, and there was a significant reduction in PA pressures and an elevation in cardiac output observed as early as 1 month after implant, and a significant NYHA class and quality of life improvement seen within 1 year. Now, in the literature, I found some very novel uses of the CardioMEMS device. One study showed 9 patients that had PA pressure monitoring, and what they found was that mean PA pressure decreased significantly from 42 to 38 millimeters of mercury after the initiation of SGLT2 inhibitors. And another study evaluated 18 patients that had PA pressure monitoring and showed a significant decrease in mean PA pressures with transition from ACE inhibitors to Entresto. And this is an interesting way to use the CardioMEMS because we can potentially see the effects of these medications that we give all the time for heart failure. And finally, this study retrospectively evaluated a cohort of 436 patients that had CardioMEMS, of which 108 went on to have an LVAD procedure. The mean PA pressure at sensor implant was higher by 29% among the patients who later received an LVAD. The mean PA pressure 6 months prior to LVAD was 35.5, increased to 39 4 weeks before LVAD, then decreased to 27% at 3 months and stabilized again to 31 millimeters of mercury 1 year later. Now, what this study showed was that patients who end up receiving an LVAD have higher PA pressures at sensor implant and these pressures continue to increase leading up to LVAD implantation with a significant reduction that persists 1 year post-implantation. And so PA pressure monitoring use in this subset of patients may aid in clinical decision-making for timing of LVAD implantation, as well as in the management of patients once they have been implanted. So in conclusion, remote pulmonary artery pressure monitoring is safe and provides actionable information. It results in greater medication changes and lower PA pressures. It reduces readmissions. It extends to specific populations and can be used in novel ways. Thank you very much. I will see if we have any questions.
I have a question, Professor An. Hi, hello. Can you hear me?
I can.
Yes. It was very great presentation. I am Dr. Lý Nguyễn from Hà Nội Medical University Hospital. I'm sorry for being late because of some technical problems. As your presentation, I'm very I'm happy to hear about the information you have shared because as my daily work, I have dealing with many patients with pulmonary arterial hypertension. However, the group of patients you have mentioned here is a patient with left heart disease. So that means the group 2 PH. So I have some questions for you related to the use of CardioMEMS. As you mentioned, you specialize in the hospital when you take a large number of heart transplantations. So the use of CardioMEMS for patients with heart failure is very important to measure the change in the pulmonary pressures in response to treatment. However, do you put the CardioMEMS for patients with other groups of pulmonary hypertension, for example, group 1? And when you put the CardioMEMS implant the device, how long you will put in the patient, or can it be removed after a time putting in the patient, or we have to put it lifelong for the patient? Whether this device is worked by battery or like cardiac pacing or any means for the device to work in the patient. Thank you very much.
So thank you for your questions. They're great questions. The first one was about if at the University of Chicago we implant CardioMEMS in other groups of pulmonary hypertension other than group 2 due to left heart disease, correct? And the answer is no, not really. I do think, I did present one study that was very small that looked at the safety and applicability of the CardioMEMS in pulmonary arterial hypertension. And I do think that study was promising, though in very, very small amount of patients. I do think it's a patient population that would benefit from it. But we don't do it. It's not standard of care at this point in time. The second question that you had was about lifelong, right? So once you implant the CardioMEMS, it is lifelong. Plavix is required for 30 days after implantation, and then aspirin if they can lifelong, but it's not necessary. But it is something that's implanted lifelong, I suppose, and I think that someone else may be able to answer this better than me, but I'm sure it can be retrieved if necessary. And then lastly, what was the last question again?
How it works? It's lifelong. Is it run by battery or how it? Because of some for pacing, we have to change the machine after we run our battery. So for the CardioMEMS device, can we have to change?
No, it doesn't run by battery. It has I'm not completely familiar with how it works, but it has a sensor and a capacitor, and that doesn't require any power to work. And the patients sit on a pillow every night, and that generates from the PA pressures some sort of waveform that can be detected by the pillow and then sent to a cloud. So that's basically how it works. It doesn't require battery at all.
Thank you. So do you have any idea of the device in terms of how big is the device and where the device will sit on which place in the artery, the pulmonary artery, the device will sit on, and what will keep the device not change the place inside the patient when the patient move around? Can you share?
I do wonder if Bác Nguyen from Indiana, do you implant CardioMEMS?
Yes, we do CardioMEMS, and
he's better to answer this question.
We don't have any problem with if the patient move or patient in position, and the monitoring of the CardioMEMS measures the pressure is by ultrasound so we don't have to worry about that part. When we deploy the CardioMEMS, you put at the distal part of the pulmonary artery, and it's stuck there. So it doesn't move. We have to be sure it doesn't move. So we are okay with that.
Thank you, Professor. So you mean like the west catheter? The CardioMEMS will stuck in the farthest branch of the pulmonary arteries, and then it will sit there.
Yes.
So you can put it in the cath lab, or you can put it just under the cath lab. Okay, yeah. Thank you very much.
You can see it. You can see the location where we put the CardioMEMS.
So what is the price of the device, and is it do you think it can be acceptable for Vietnamese patients in terms of its benefits in guiding treatment for the patient? Thank you.
Dr. An, this is for your answer.
Well,
she asked for the price and affordable for Vietnam.
I don't know the price, but I would say it's probably not affordable for Vietnam. It's sometimes very hard to even have insurance approve of it here in the United States. Sometimes we have to fight for it despite such compelling evidence in the trials. But I thought maybe you would know more than me about how much it costs. Maybe 30,000?
30,000? So if with that price in reality in the US, on average, how many percentage of the patient with pulmonary hypertension can afford for that device? as you mentioned, the insurance that does not cover for that device?
I also don't know those statistics as well, but remember, it's indicated for heart failure, and a lot of the heart failure patients that end up getting a CardioMEMS also have some sort of pulmonary hypertension. But group 2, it may be a component of fixed PAH, right? But yes, again, it's for heart failure, not PH. But I don't know the answer about the statistics.
I have two things for you. Number one, once the panelists ask, can we do research in Vietnam in this CardioMEM for you? And please look at the chat box. There is a question for the doctor from Taiwan, Dr. Yu Feng Hu. Please, you have to address that question and invite Dr.
Yes.
to answer the question. Thank you.
So, Dr. Yu Feng Hu, there is a question, and I'm sorry we have abandoned and neglected you here, but the question is, as a screening tool, SET2 in Japan, the population is better due to a higher sensitivity. Can you comment on that, please?
Okay, so that is the problem when we try to apply our model in different hospital or different countries. So we are not doing the validation in Japan only. So we are facing the same problem when we apply this to a different hospital. I think that this is a common problem when we try to apply AI model. As you show in the paper or the other hospital like Korea or the Mayo Clinic, we are facing the same problem. So you need to module or change your sensitivity or specificity during the test in the other hospital. Especially when we are doing the study in Japan, these are different ethnic, and there's also different machine. So different machine have a different filter system and acquiring system. So that's the thing when we try to do the first test for Japan, we observe the high sensitivity and the specificity issue. So we will move to the second step to modify the acquiring system and try to we can change the threshold by the AI model in a different system. So we will, in the second test, you need to change your threshold for the sensitivity and specificity. And that's the thing, because I think all the data will question about the specificity. So that's the thing you need to modify in the second step. And I think that's a common thing when you try to apply AI model, especially you apply this in different country, different system, different ethnic. So that's a thing. That's a really good question, but that's definitely the issue you need to solve when you try to use the system worldwide.
Thank you so much. So it's perfect timing for us to move on to the second part of our session. We are going to start it off with Dr. Nguyen, who is going to be speaking about roles of vasodilators in pulmonary artery hypertension and heart failure management. She is a cardiologist at Hanoi Medical University Hospital, and we're excited to hear what she has to say today.
Good morning again on the board of the symposium. I'm so sorry for the technical, because I have a record in Vietnamese. However, in this section, I think I would be prefer to present online in English, because all of the faculties will discuss in English. So my topic will be the role of vasodilator in treating pulmonary hypertension in patients with heart failure. I'm working in the Department of Cardiology, Hanoi Medical University, and also the Vice Director of the Heart Center, Hanoi Medical University Hospital. My specialty is internal cardiology, echocardiography. I'm also interested in congenital heart disease and pulmonary arterial hypertension. I finished my PhD in 2020 in Hanoi Medical University. I also have some short short course in medicine and in cardiology in University of Sydney in 2015, in Boston School of Medicine in 2017, and in Harvard School of Medicine in 2019. I also take part in some book chapters like the clinical of cardiologists for the congenital heart disease, some textbook for postgraduate training in Hanoi Medical University. That's what I want to introduce something about myself. And now I will move to my topic. The first slide, I would like to revise you with the classification of pulmonary hypertension. We have 5 groups, and the groups I want to spend talking today is a group 2, that is PH due to left heart disease, including PH with left heart failure, preserved EF, and left heart failure with reduced AF. And the definition of pulmonary hypertension based on hemodynamics, we classify into pre and post capillary. For pre-capillary PS, we are familiar with a group 1, group 3, group 4, and group 5. When we base on the pulmonary capillary wedge pressure, it must be less than 15 millimeter mercury. For group 2 or the left heart disease, the pulmonary hypertension belongs to the post-capillary isolated or combined pre and post capillaries. In this case, we have a pulmonary capillary wedge must be more than 15 millimeter mercury, and the based on the isolated or combined, it will differ from the pulmonary vascular resistance, less than 3 or more than 3 Wood unit. And here is the illustration of the pathology of pulmonary vessels in patients with pulmonary hypertension due to left heart disease. People believe that there are around 15% of patients with pulmonary hypertension due to left heart disease have the chance of the pulmonary vascular chains close to the chains we see in the patient with pre-capillary pulmonary hypertension, including the hyperplasias of the intima, the hypertrophic of the middle layer of the vessels, and the fibrosis of the outer layers of the vessels. This also, we can see these structures in the pulmonary vein in patients with pulmonary hypertension and left heart disease. As I have mentioned, the pulmonary hypertension in patients with left heart disease is a really challenging issues because of the unclear definition, whether it related to post-capillary pulmonary hypertension or combined capillary pulmonary hypertension, and the prevalence is still unclear. It states that there are 70% of patients with PH is due to left heart disease, and in a third of patients with heart failure, they will have hypertension. And the symptoms in patients with pulmonary hypertension due to left heart disease is, sometimes overlaps with the symptoms of pulmonary hypertension and symptoms of heart failure. and still now we haven't had any PA-specific medication for treating the pulmonary hypertension in patients with left heart disease. And this group of patients has the poor prognosis, and even the scientists have had a great effort to run many trials. So the data and the studies now are very limited for this group of population. We see there are three pathways in the mechanisms in treating the patient with pulmonary arterial hypertension, including the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. Here is a three pathway we can use PAS targeting drug for patients with pre-capillary pulmonary hypertension. However, with a patient with left heart disease, none of these medication have been proven to be beneficial because the number of patients with pulmonary hypertension and left heart disease is very has a large proportion, and when they develop pulmonary hypertension, they increase the risk of mortality and morbidity. So the target treatment for the pulmonary hypertension in this group of patients is still receive a lot of interest and studies. And in elderly patients, the heart failure, in adult patients with heart failure, the nitric oxide have plays an important role in stabilize the pulmonary vascular in the normal range. Patients with pulmonary hypertension due to left heart disease has seen the increase in the concentration of endothelin in the plasma, and it is related to the degree of pulmonary vascular resistance and increased pulmonary pressure. Here are some trials in the use of medication for treating pulmonary hypertension in patients with left heart failure. Authors have make the studies in the use of sildenafil. Is a kind of PDE5 inhibitors, or riociguat is a kind of direct stimulators of solute guanine class, or macitentan is a kind of endothelin inhibitors. The number of patients in each study is not a very big one, and the duration for trials is around 3 to 12 months. And the populations, including the patient with left heart failure, either preserve EF or reduce EF with pulmonary pressure increase. And the results, we have found that with most of the studies, we have seen no change, no improvement, or no benefits in improve the value of pulmonary pressures or pulmonary vascular resistance, or even the symptoms of patient with pulmonary hypertension with left heart disease. So the 2015 guidelines of ESC-ERS in patients with pulmonary hypertension due to left heart disease, they show that until that moment, there haven't any trials multi-center that have shown the role of pulmonary vasodilation in treating the pulmonary hypertension show beneficial with the condition of pulmonary hypertension in patients with left heart disease. Therefore, the use of targeted medication in treating patients with PAH is not recommended in patients with pulmonary hypertension due to left heart disease, the class 3 and level of evidence C. Even with the guidelines and the results from the trials, it's not increasing. Still new trials and in pulmonary hypertension due to left heart disease still carry on. So why the scientists still very interested in that issues? Because as we have mentioned, it's really a big issues, and we have very limited data on this, and still the scientists really want to do further studies to whether to get any benefits in some subgroup of patients with pulmonary hypertension in left heart disease. And in those trials, I want to tell about the dynamic trials. It's the trial of using Rio silhouette. And we will see the change, whether it causes a change in the cardiac output. One registry is Compera registries. We assess the first time using medication in treating pulmonary hypertension in patients with comorbidity and in patients with pulmonary hypertension and heart failure with preserved EF. In this Compera cohort, we will recruit 800 patients in to the studies, and in 800 patients we have 560 patients with typical and atypical IPAH, and 230 patients with pulmonary hypertension due to heart failure with preserved EF. And we can see in the results of the Compera registries, we see that the rate of discontinuations of medication is seems higher in the group of patients with left heart disease compared with patient with pulmonary arterial hypertension, due to lastly the effect. The efficacy is as not as the author expected, and the survival between the three groups of typical IPAH, atypical IPAH, and PAH related to heart failure. So survival is seems lowest in the group of patients with left heart failure. And the change in the 6-minute walk distance and the functional class, and also the value of NT-proBNP in the group of patients with heart failure is seems less in compared with patients with IPAH, typical and atypical. So from the Compera registry, we have found that pulmonary hypertension may be typical PAH, maybe atypical PAH, and maybe a part related to left heart failure, and a part pre-capillary. So the as in this way, we can see the proportion of free capillary part is decreased when we move towards the PS with left heart disease. And the increasing risk factor if we move to the PS with left heart disease, including age, obesity, hypertension, diabetes, coronary artery disease, or atrial fibrillation. And with this, when we come from typical to atypical to PS due to left heart disease, so the efficacy of targeted PS therapy seems decreased, and the side effects related to the use of this group of medication is increasing. There's another study I want to mention here is a dynamic study. Is trials of the multi-center phase 2B randomized double-blind placebo-controlled parallel group trial to test the use of Riociguat in patients with pulmonary hypertension due to heart failure and preserved EF. And the key inclusion criteria, the patient with heart failure, preserved EF, and the post-capillary pulmonary hypertension. With the test result, whether Riociguat can improve the hemodynamic in patients with pulmonary hypertension and heart failure preserved EF. Riociguat is a kind of oral solute guanine C-class, and they have the role in increase the sensitivity of solute guanine C-class with the intrinsic nitric oxide, and the role of stimulus of guanine C-class solute depends on the concentration of nitric oxide. And the pathway of nitric oxide solute guanine C-class have the role of vasodilation, anti-proliferation, anti-inflammation, and anti-fibrosis. And here's the baseline of the population in the trials. We have the very consistent characteristic between the arms of Riociguat and the arms of placebo in demographics, in comorbidities, in the treatment for heart failure, and the in echocardiography and hemodynamics. And the results of the trials show the improved in the cardiac output in compared with placebo in patients use Riociguat after a time of taking in the trials. And also there's in the decrease in the trans gradient pressure gradient, and but no change in the pulmonary wedge pressure. So the conclusion from the dynamic trials, so the long-term treatment with Riociguat can improve the cardiac output and can reduce the pulmonary vascular resistance, and also the DPG. However, the capillary wedge pressure and the systemic vascular resistance have not been affected. And with Riociguat is very safe and well tolerated in patients. However, the studies need to be further to assess the role in improve the symptoms and also the prognosis with patients with heart failure preserved EF. Another direction that this year ESC guidelines of heart failure have mentioned is not focused on the pulmonary hypertension. However, also in the patient with heart failure, they have put in the guideline the indication for very cigarette in patients with heart failure and reduced ejection fraction when they have a Victoria trials, and in Victoria trials they will assess the role of vericiguat is a kind of direct soluble class, also in the road of patient primary endpoint, the time to first occurrence of the composite of cardiovascular death and hospitalization because of heart failure. And here we can see the mechanisms of vericiguat. It also affect the pathway of nitric oxide, and it has an effect on the vasculatures, similar to in the pulmonary vascular resistance. It will decrease the arterial constriction based on the effect on the vasodilation, and it also decrease the vascular stiffness, and also it has an effect on the heart in the way of decrease the progressive of myocardial stiffening, decrease myocardial thickening, decrease the process of remodeling ventricular and the fibrosis. So the patient with chronic heart failure and have the event of worsening HF will have when treatment with the vericiguat. And the primary endpoint, so the vericiguat have to decrease the time to cardiovascular death or the first hospitalization due to heart failure, 4.2% compared with placebo, and with the number needed to treat is 24. The secondary outcomes with patient with vericiguat will have the decrease in the total hospitalization due to heart failure, and on-call mortality was significantly reduced with vericiguat compared with placebo. And the safety profile is very good for vericiguat. Just have the symptomatic hypotension and syncope. However, there's no difference between the vericiguat and the placebo arms. With the result of the Victoria trial, vericiguat become the indication in the 2021 ESC guidelines in the treatment of patient with NYHA class 2 to 4 who have worsening heart failure despite treatment with medication for heart failure, and to reduce the risk of cardiovascular mortality or hospitalization because of heart failure. And vericiguat may be considered for the treatment of patients with worsening heart failure in the way of heart failure, not the way of pulmonary hypertension. However, this group of medications share the same medication action in 1 in 3 pathways I have mentioned in the pathway of treatment with PAH. So in conclusion, PAH targeted medication in pulmonary hypertension due to left heart failure. Before we decide to use this group of medication, we should make a very detailed diagnostic steps to differentiate between whether the patient have IPAH or the pulmonary hypertension due to left heart failure. And with patient with pulmonary hypertension with left heart failure, the most important is we have to optimize the treatment of left heart failure, and we should always remember the treatment of comorbidities in patients, for example, diabetes or hypertension or COPD. And we never use medication for treating pulmonary hypertension in patients with heart failure, similar the way we use in patients with pulmonary arterial hypertension, because it isn't recommended in the guidelines, and it isn't provide benefits in the clinical trials. However, ongoing trials have been carried on to see whether that group of vasodilation can have use in the treatment of pulmonary hypertension, and we're waiting for the optimal result in the futures. And the last is for the medication of stimulating solute guanine C-class vericiguat is indicated in patients with heart failure with reduced EF, with a patient would have worsening heart failure based on the treatment medication treatment optimal. And this is class 2B level of B. This above all is what I have want to share about the vasodilation in the treatment of pulmonary hypertension in patients with left heart disease. I'm very thank you for all of you for the listening. Thank you very much.
Thank you. That was great. We're going to quickly move on to our last talk from Dr. Xiaoling Chen, entitled Pulmonary Denervation is Useful for Heart Failure Management or Not.
Thanks, organizer. My presentation is pulmonary artery denervation. Is it useful for heart failure or not? So let's go through the physiology mechanism of pulmonary circulation. Basically, pulmonary circulation is characterized by low pressure and PVR according to Purcell formula. So the change of pressure across a given vessel segment is mainly determined by the change of vessel diameter. So small reduction in the vessel diameter can lead to a dramatic increase in pulmonary vascular resistance. So in terms of the different etiology of the change of pulmonary circulation, for example, for patients with CTEPH, because classified by precapillary pulmonary hypertension, and left heart failure induced pulmonary hypertension. So it's defined as a post-capillary pulmonary hypertension. So a few years ago, neurological study has demonstrated the pulmonary artery is innervated by sympathetic, parasympathetic, and sensory nerve fibers. In contrast to most other organs, innervation density is the highest at a large caliber vessel and decrease towards the peripheral So from the distribution of node density, you can see, so the highest density at the crossing pulmonary artery, but it was diminished over the distance to the peripheral. So a few years ago, our group published the identification of the change of alpha-1D receptor in smooth muscle cells among the animal with target-induced heart failure. So you can see at the 6 weeks of the induction of experimental model of heart failure, so the density of alpha-1D receptor increased by almost 3 times. On the right panel, you can see for animals with the pulmonary artery denervation by surgery and immediately after the induction of the target model, so there was a significant reduction of the smooth muscle cell thickness and enlargement of pulmonary arterial lumen. So from 2012, we started to design PAD-1 phase 1 study, including only 13 idiopathic pulmonary arterial hypertension, and 2 PAD-1 phase 2 included consecutive 66 patients with different etiology, idiopathic group 1 pulmonary arterial hypertension, and also hypertension secondary to heart failure, CTEPH. And after that, we realized the importance of the change of sympathetic nose tone in patients with heart failure-induced combined precapillary and post-capillary pulmonary hypertension. So we designed the PAD-5 trial. This is the first trial to demonstrate the safety efficacy of pulmonary artery denervation for patients with CPC-PH secondary to left heart failure. So this is the study published in JACC Cardiovascular Intervention and presented in TCT 2018. So the background included heart failure is a common final stage of most cardiovascular disease. The backward transmission of increased left ventricular filling pressure results in elevated pulmonary venous pressure. This is called IPC-PH. Long-lasting of IPC-PH leads to CPC-PH, which accounts in 12 to 13% of all patients with heart failure. Routine treatment of CPC-PH with drugs targeting group 1 PAH is not recommended in current guidelines. CPC-PH is associated with superimposed pulmonary arterial vasoconstrict and overactivation of the sympathetic nodes. Pulmonary artery denervation PAD has never been studied in a randomized comparison with a medical treatment. So this is the study design of PAD-5 of 860 patients with heart failure who have been stable for minimum 3 months, and also because of the recent worsening of heart failure, admitted to the hospital. And also the patient in hospital, maximum anti-heart failure medications, and the patient who were restabilizing for minimum 3 days. Of these patients, 387 patients had a systolic pulmonary arterial pressure minimum 45 mmHg by cardiac echo. So these steps are the basic screening for the patient to be included in this study. After cardiac echo measurement, so 112 patients were defined as CPC-PH by right heart catheterization. Of them, 10 patients did not consent, and 2 died before the enrollment. So finally, 98 patients with 50 in the sham group and 48 in the PAD group were randomized assigned. So the inclusion criteria included minimum 18 years, mean pulmonary arterial pressure minimum 25 mmHg, PCWP larger than 15 mmHg, PVR higher than 3.0 unit. And also patient did not receive any medication targeting group 1 PAH in the last 3 months prior to the admission. There was no specificity for the exclusion criteria, but the important exclusion criteria was the renal function, so defined as the change of CCR less than 30. So this is the protocol procedure to define the steps of the study. Basically, transthoracic echocardiograph 6 months after recruitment was required, right heart catheterization at 6 months after randomization should be performed. Also, NT-proBNP before and 6 months after study were measured for all patients. After the procedure was following for patients with atrial fibrillation, but for non-atrial fibrillation patients, aspirin and clopidogrel were prescribed for maximum 1 month after the procedure. The primary endpoint was the change of 6 minutes walk distance. We also provided several secondary endpoints, including PVR by right heart catheterization, clinical worsening, and safety endpoint, including suspected or fatal PE. So there was no significant difference in terms of the baseline characteristics between PAD group and sham group. At 6 months follow-up comparing with the baseline variables by echocardiographic showed in this table, you can see there was no change in terms of the different variables in sham group, but in PAD group, systolic pulmonary arterial pressure, left atrial diameter, left ventricular diameter, left ventricular ejection fraction, as well E by E ratio, TAPS, and also RV10 index, all improved significantly after PAD and procedure at 6 months follow-up. So from the table, we can calculate the improvement of left ventricular function by pulmonary artery denervation. So significantly, basically our concern was a worsening of left ventricular ejection fraction. But from the table, you can see the increase of LVEF was around 10% by PAD group compared to negative 4.8% in the sham group. Finally, we did not identify the change in right atrial diameter between 2 groups in PAD and also sham procedure. By right heart catheterization, from table you can see there was no change of the right atrial pressure at 6 months follow-up after either sham and PAD procedure. Particularly, systolic pulmonary arterial pressure, mean pressure, cardiac output, cardiac index changed very, very significantly. Particularly, the pulmonary vascular resistance decreased from 6 to 4 units after PAD procedure at 6 months follow-up with very significant p-value. And also, from the figure, you can see this is the baseline 6-minute walk distance, the primary endpoint in the study. No difference between 2 groups. So the mean value of 6 minutes walk distance was 344 meters compared to 351 meters in the PAD group. But at 6 months follow-up, the increase of 6 minutes walk distance after the PAD procedure increased by 18 meters compared to only 17.5 meters in the sham group with very, very significant p-values. Also, this is a secondary endpoint, clinical worsening. it was only 6.7% in the PAD group compared to 40% of the sham group. So this result reminded us the requirement of next clinical trial to define the improvement of clinical outcome in patients with CP-CPH after PAD procedure. So ladies and gentlemen, in conclusion, PAD-5 trial demonstrated the benefits of PAD for patients with CP-CPH. And also from our subgroup analysis, both heart failure with preserved EF and heart failure with reduced EF equally benefited from PAD. No sign showing the harm of sildenafil to CP-CPH. But from our study, we do find the non-change, non-improvement of hemodynamic exercise capacity and clinical outcomes in patients from sham group. Thanks for your attention.
That was wonderful. I'd like to open up questions to everybody else. Anyone on the panel? Comments? Well, I have a question. Do you think could you explain to me how this denervation is done?
I will, this is Dr. Thach Nguyen here from Indiana. I work very closely with Dr. Shaolin Chang at Nanjing University, and we published together the first paper on pulmonary artery denervation study on JACC, in JACC. At that time, the one from the editor-in-chief is from University of San Diego. I forgot his name. And the way it is, we use, you see that in one of the slides, he shows that the catheter, it looked like the catheter for the atrial fibrillation ablation with the ring. And on that ring, it connected to the electrical device so we can give shock to the area. And the areas they do denervation it at the basal, at the proximal segment of the pulmonary artery. And when it's similar to the ablation for AFib. And when they do that, they damage the sympathetic nerve at that area. And then from that, they cause less vasoconstriction in the distal vasculature. Because you remember at the first few slides, he mentioned that the mechanism of pulmonary hypertension is due to capillary vasoconstriction. So this is a general situation for the general principle for the pulmonary artery denervation procedure.
And what is the? I'm very curious about this now. Actually, what is where do you guys stand with this? Are you implanting more? Is it here in the United States?
Most of the case done, it is most of the time done in China, the first study. But in this study, he did for the patient with heart failure, and most of the patients are in China. He did do the demonstration in Europe, in the US, or in Russia. Is that what I know? But in this study, they did for most of the patients in China. And if any time, I can invite him. If you prefer to talk to have him come to the University of Chicago, it's very easy. And then when you want to, if you want to go to give a talk in Nanjing, it's okay too. I was there many times. So to let you know that about this technique. And thank you very much.
Thank you. We do have a question in the chat box. Applying destruction of pulmonary denervation in heart failure patients in your country, is there any limits? I don't know who that's being addressed to. I would assume that that's to Dr. Xiaoling. Is he still here?
Yeah, so I reply on his behalf again, because he left the meeting and I mentioned to him that I will reply on his behalf. At this moment, there are two things in here. Number one, the intellectual properties, the copy of the patent for the catheter, and number two, it is the catheter device is not approved in the U.S. Number two, so most of the time, the patient, the study is done in China.
Professor Thạch Nguyễn, can I have a question for you?
Thank you.
Yes, thank you. As Professor An, I'm also very interested in the results of the pulmonary artery denervation. And as you mentioned, it will cause less vasoconstriction and reduce the pulmonary artery hypertension. And you mentioned you done most of the case in China. So do you think you have the intention to do that procedures in Vietnam? As I know you have a great help with the Vietnamese intervention in many areas of cardiology intervention. And the second question is, because in these trials, how long you will assess the pulmonary arterial pressure after you do the intervention, how to know whether it decreased in the pulmonary pressure and pulmonary vascular resistance. And in that case, you use catheterization or you use echocardiography. Thank you.
So again, I answer on behalf of Dr. Xiaoling Cheng. I can invite him to go to Vietnam to do the demonstration without problem, number one. Number two, as you see in these studies, and this is what I'm not very interested, I'm not very happy with. You see that they measure the pulmonary artery pressure by echo. This question is also for Dr. An Nguyen. You see, the echocardiography, we measure the pulmonary artery pressure by echo, is not all the time good and accurate. Many times we measure is high, and then we do angiography, we do right heart cath, and it is not as high as we thought. Can I have your comment, please, Dr. An Nguyen, about the measurement of the pulmonary artery pressure by echo or by right heart cath?
I 100% agree with you. In fact, if an echo read comes back with elevated pulmonary pressures, which again is dependent on not only the operator, but also the reader, there's a lot of potential for mistakes, bias to be introduced. And so if we see an elevated PA pressure on echo, we actually validate with a right heart catheterization. That's the gold standard for us for diagnosing, making the diagnosis of pulmonary hypertension.
This is the answer for Dr. Minh Le. Thank you very much.
Thank you very much. Actually, I want to small comment, but the authors have to leave. But because in this his trials, he have two groups of patients. Group one, which he used Sinafil, and group two with the intervention. However, this is not blind trials, so it can affect the assessment of the results of the especially in echo when we measure the EF and the pulmonary arterial pressures after the intervention. And also one more comment is if is it the rate of I mean, you do like AF ablation. So how much ablation you will denervation, and how to show is it enough and is can successful of the intervention. Thank you. Professor Thành Nguyễn.
Yeah.
Yeah.
I remember the second part of the question was a technique, how long and how extensive we have to do ablation for that one. I don't know, because that one I don't know. But I don't remember the first question about, you talk about the design of the study. She says that how we can blind the study, you see? How we can, so if we can do that, we have to do a sham study for the patient. Every patient will have the ablation, but one group we put the catheter in, but we don't activate the equipment, and the other group we put the catheter in, but we activate the device. This is how we can randomize and we can blind the study. This is a design, and I agree with you that according to the study he showed, and it is presented at the TCT in 2018. And so to say that it is not blind, but it could be done if we want to blind the study. You see, one of the design. I agree with you about that. Yeah.
Thank you.
May I have a question, Dr. Thành Nguyễn?
Thank you very much, Dr. Trương Thanh Hương. Dr. An Nguyen, Dr. Trương Thanh Hương is a senior cardiologist at the Vietnam Heart Institute, and she had a lot of patients with congenital heart disease. Please, Dr. Trương Thanh Hương.
Thank you for your introduction. As a safety denervation, do you think we can use this tool for the pregnancies, hypertension, artery, pulmonary hypertension with other congenital heart disease? Because in the practice, we usually see this kind of patients.
So you mentioned about the patient with pulmonary hypertension caused by pregnancy.
No, the pregnancies with other congenital heart disease.
Again, from my part, I understand the study was done in China, in Nanjing, and we didn't have any patient with this kind of problem. This means congenital heart disease. Now, Dr. An Nguyen, this is a very important question. Can you answer this question from the point of view from the University of Chicago?
Are you talking about doing the pulmonary artery denervation or the cardiomems for congenital heart?
We just talk about, we don't talk about denervation here because at the University of Chicago, the procedure is not approved yet, so we don't do it. So
right.
We just say that, what do you think about the question from Dr. Trương Thanh Hương?
So I'm going to have to get a little bit more clarification about the question, though. The question was about pulmonary hypertension in congenital heart disease, correct?
Yeah.
And in general at Chicago, how do we manage it, or?
Yes.
Okay. So this is a tough question for me to answer simply because I work at a tertiary center. And so the congenital heart disease that we see with significant pulmonary hypertension are patients that have been referred to us and are being evaluated for heart transplant or heart lung transplant, which we don't do at the University of Chicago. So I commend you for taking care of that patient population. I would love to come and work with you for a week just to see the patients that you see, because they're very difficult. And we are getting a message that time is up. So
now, Dr. Thanh Hương, please invite, and Dr. Minh Lý, please invite Dr. An Nguyen to come to Hanoi. because she wants to see your patient over there.
It's
I
a
do.
great idea.
Very
Thank you.
welcome.
Okay, great session. Thank you so much.
Thank you so much. Thank
Goodbye.
you very much. Bye bye.
Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021.
Chào mừng các quý thầy cô và các bạn đồng nghiệp đã đến với phiên hội thảo những tiến bộ mới trong thăm khám và chăm sóc người bệnh tim mạch. Hội thảo được là sự phối hợp giữa Hội Tim mạch học quốc gia Việt Nam với công ty Abbott đồng tổ chức. Tôi là tiến sĩ bác sĩ Phan Đình Phong, Tổng thư ký phân hội nhịp tim Việt Nam đến từ Viện Tim mạch Việt Nam, và rất chào mừng các quý vị và các bạn đã có mặt trong hội thảo buổi trưa hôm nay. Và đồng hành với tôi là các báo cáo viên, là những chuyên gia hàng đầu trong lĩnh vực điện sinh học tim cũng như tạo nhịp tim tại Việt Nam, và một vị khách mời rất đáng quý đến từ Singapore. Tôi xin trân trọng giới thiệu đầu tiên là Thạc sĩ Trần Lê Uyên Phương, Phó khoa điều trị rối loạn nhịp tim đến từ Trung tâm Tim mạch Bệnh viện Chợ Rẫy. Người báo cáo viên thứ hai từ Việt Nam sẽ là bác sĩ Đỗ Văn Bửu Đan, trưởng khoa nội tim mạch và điện sinh lý tim đến từ Bệnh viện Tim Tâm Đức. Và đặc biệt chúng tôi hân hạnh chào đón tiến sĩ bác sĩ Regina Liu đến từ giám đốc trung tâm tim mạch The Harley Street, Singapore, sẽ tham gia báo cáo và thảo luận cùng với hội thảo ngày hôm nay. Để mở đầu chương trình, chúng tôi xin trân trọng giới thiệu và kính mời Thạc sĩ bác sĩ Trần Lê Uyên Phương sẽ trình bày chủ đề đầu tiên: đại dịch COVID-19 đã làm thay đổi quy trình quản lý và theo dõi bệnh nhân rối loạn nhịp tim như thế nào. Xin được nói thêm một chút là Thạc sĩ bác sĩ Trần Lê Uyên Phương là một trong số rất ít những người phụ nữ quả cảm đã theo đuổi lĩnh vực EP tại Việt Nam. Tuy nhiên là Thạc sĩ Trần Lê Uyên Phương đã đạt rất nhiều thành tựu, và từ Hà Nội cũng như các trung tâm tim mạch khác, chúng tôi đã chứng kiến rất nhiều những cái tiến bộ, những cái sự phát triển kỹ thuật rất là mạnh mẽ từ bệnh viện Chợ Rẫy. Bây giờ tôi xin nhường lời cho Thạc sĩ Trần Lê Uyên Phương.
Dạ, em xin cảm ơn phần giới thiệu hết sức ấn tượng của tiến sĩ Phan Đình Phong. Thì hôm nay em rất là hân hạnh được trình bày trước Hội nghị Tim mạch Toàn quốc năm 2021 giữa đại dịch Covid-19. Chúng em bài nói chuyện hôm nay chỉ là chia sẻ những thực tế mà chúng em đã gặp phải trong cái đợt dịch vừa qua. Như quý anh thầy cô và các anh chị đã biết, đợt vừa qua thành phố Hồ Chí Minh phải hứng chịu một cái đợt Covid nặng nề. Gần như là trong suốt 4 tháng chúng em chỉ điều trị Covid và mọi hoạt động về hành chánh và quản lý cũng xung quanh những cái bệnh nhân Covid và Covid mà thôi. Vì thế quả là cuộc sống của chúng em đã thực sự là đảo lộn. Thì hôm nay chúng em xin trình bày những cái sự đảo lộn mà chúng em đã hứng phải trong 4 tháng vừa qua. Thì thực sự qua 4 tháng vừa qua, đại dịch Covid-19 đã thay đổi phương thức quản lý những bệnh nhân rối loạn nhịp. Chúng em bắt đầu học thế nào là rối loạn nhịp ở bệnh nhân nhiễm Covid-19 và tìm cách xử trí những rối loạn nhịp ở bệnh nhân Covid-19 như thế nào, ở khoảng cách gần, ở khoảng cách xa. Ngoài ra, những bệnh nhân rối loạn nhịp của chúng ta đã theo dõi từ lâu, hiện nay không thể đi lại được do tình hình Covid-19, chỉ thị 15, 16, thì chúng ta sẽ quản lý như thế nào, cập nhật những guideline trên thế giới như thế nào và áp dụng tại tình hình thực tế tại Chợ Rẫy của chúng em ra sao. Thứ ba là qua cái tình hình mà đi lại khó khăn đấy thì chúng tôi nghĩ đến là thế thì cái việc quản lý bệnh nhân với các thiết bị theo dõi từ xa quả thật là hiệu quả và nó sẽ rất giúp ích cho bệnh nhân trong cái thời đại Covid ngày nay. Thì trước tiên em xin bước vào những cái rối loạn nhịp do Covid-19, những bệnh nhân Covid-19 có thể có mà chúng em đã tham gia điều trị. Thì thực sự là Covid-19 là một cái bệnh do virus gây ra, tuy nhiên nó gây ra những cái tổn thương, đặc biệt ở tưởng nó tổn thương ở cơ tim, ở mạch máu, đặc biệt là động mạch vành thì cũng được quan sát thấy. Về rối loạn nhịp là một trong những tổn thương của Covid-19 do các yếu tố khởi phát rối loạn nhịp ở bệnh nhân Covid-19 bao gồm các tổn thương cơ tim do Covid, do sự tăng điều hòa thụ thể ACE2 trong quá trình xâm nhập của virus vào cơ tim và động mạch vành. Đồng thời, nó cũng có những yếu tố khởi phát rất là đáng kể do tình trạng suy hô hấp cấp, giảm oxy máu nặng nề. Ngoài ra, tình trạng nhồi máu cơ tim do tăng đông hoặc là tình trạng nhiễm trùng, tình trạng viêm, các rối loạn điện giải do Covid mang lại, thứ phát sau tiêu chảy. Tiêu chảy cũng là một cái triệu chứng khi nhiễm Covid-19 do suy thận cấp, do tổn thương đa cơ quan, do nhiễm trùng nặng, suy dinh dưỡng, hay một số bệnh nhân có sẵn các bệnh lý keny âm như hội chứng Brugada hoặc hội chứng QT dài chưa được phát hiện. Khi mà sử dụng các thuốc chống virus thì những cái biểu hiện Brugada hoặc QT dài nó sẽ lộ lên và gây ra những cái cơn rối loạn nhịp nguy hiểm đến tính mạng. Đặc biệt những bệnh nhân có mang hội chứng Brugada, khi mà bệnh nhân có sốt do Covid, do sự nhiễm Covid thì cái biểu hiện của điện tâm đồ nó sẽ thể hiện rõ rệt hơn hẳn. Thì trong quá trình điều trị rối loạn nhịp ở những bệnh nhân Covid-19, chúng tôi nhận thấy có rất là nhiều bệnh nhân có nhịp chậm xoang hoặc rốt nhị thất. Đa số bệnh nhân có một cái tình trạng nhịp chậm hơn so với thân nhiệt của cơ thể của bệnh nhân, tương tự giống như khi tình trạng nhiễm thương hàn, tức là bệnh nhân có sốt 39 độ C nhưng nhịp tim chỉ ở khoảng 90 đến 100 lần một phút, gọi là phân ly mạch nhiệt. Một số bệnh nhân có nhịp chậm xoang hoặc lốc nhĩ thất do nguyên nhân thiếu oxy máu nặng, do viêm, rối loạn hệ thần kinh tự chủ và thuốc. Đặc biệt cái việc rối loạn hệ thần kinh tự chủ do cường phế vị xảy ra tương đối thường xuyên khi bệnh nhân được chăm sóc y tế như là hút đàm nhớt ở phế quản hay là xoay trở vỗ lưng, thì những cái nhịp chậm do cường phế vị xuất hiện khá nhiều. Khi mà theo dõi bằng telemetry ở những cái bệnh nhân nặng mắc Covid-19 thì đôi khi chúng ta thấy xuất hiện những cái đoạn nhịp chậm xoang hoặc thậm chí là block nhĩ thất. Tuy nhiên những cái dạng này thường nó chỉ thoáng qua, và nếu kéo dài ở những cái bệnh nhân lớn tuổi thì ekip của tụi em chỉ đặt máy tạo nhịp tạm thời để giúp ổn định huyết động và đợi bệnh nhân hồi phục và đánh giá. Thì trong quá trình đó thì có rất là ít bệnh nhân sau khi khỏi Covid thì tình trạng nhịp chậm tái diễn mà phải cần phải đặt máy tạo nhịp vĩnh viễn. Có rất là ít bệnh nhân sau khi thoát khỏi Covid thì đánh giá lại vẫn có tình trạng suy nút xoang, có lẽ là nó tiềm ẩn do tuổi già và nó sẽ bộc phát và được theo dõi trong quá trình nhiễm Covid. Sau khi khỏi Covid thì bệnh nhân sẽ được đánh giá lại và đặt máy tạo nhịp vĩnh viễn. Một trong những cái rối loạn nhịp thường gặp thứ hai mà chúng tôi quan sát thấy ở bệnh nhân nhiễm Covid-19 đó là rung nhĩ. Thì cơn rung nhĩ có thể bị kích hoạt trong đợt nhiễm Covid như sốt hoặc là tăng hoạt catecholamine ở những cái bệnh nhân viêm phổi nặng, ARDS và nhiễm trùng huyết. Có lẽ những nhóm bệnh nhân này tần suất rung nhĩ cao hơn, chiếm đến 22 đến 23% ở những cái bệnh nhân đã có tiền căn rung nhĩ trước đó, hoặc là chiếm khoảng 10% ở những cái bệnh nhân mà rung nhĩ mới xuất hiện. Thế thì việc điều trị rung nhĩ ở bệnh nhân Covid-19 chúng tôi sẽ chú ý đến một cái số yếu tố kích hoạt và duy trì rung nhĩ trong bệnh cảnh này như hạ kali và hạ magie máu, toan chuyển hóa, sử dụng các thuốc tăng co bóp cơ tim, thở máy không đồng bộ, quá tải tuần hoàn hoặc bệnh nhân bị tăng trương lực giao cảm do tình trạng viêm thiếu máu, bội nhiễm và tổn thương cơ tim. Thế thì việc xử trí rung nhĩ ở bệnh nhân Covid-19 như thế nào? Thực sự ra cũng không có gì khác, cũng bao gồm kiểm soát tần số, kiểm soát nhịp và phòng ngừa thuyên tắc. Và việc phòng ngừa thuyên tắc bằng các thuốc kháng đông để tuân theo cái bảng điểm Just-VAX score mà thôi. Tuy nhiên có một số lưu ý, bởi vì bệnh nhân Covid-19 nhập viện thì đa số đều sử dụng cái kháng đông phòng ngừa. Tuy nhiên nếu bệnh nhân có phát hiện thêm rung nhĩ thì chúng ta nâng liều lên thành liều điều trị. Và một số bệnh nhân Covid nặng khi đặt xong mũi dạ dày rồi thì việc điều trị kháng đông bằng các thuốc kháng đông đường uống để giảm cái giảm tải là tiêm chích cho ekip điều dưỡng. Thì có một số lưu ý là cái viên dabigatran thì chúng tôi sẽ không sử dụng qua đường xông mũi dạ dày, bởi vì viên dabigatran được thiết kế để hấp thu tại ruột, và nếu như mở vỏ nang sẽ làm tăng 75% sinh khả dụng của thuốc và tăng nguy cơ xuất huyết tiêu hóa cho bệnh nhân. Do đó chúng tôi nếu bệnh nhân đặt xong mũi dạ dày thì các thuốc mà NOAC thường dùng đó là apisapan và rivaroxaban chúng ta có thể nguyền bơm qua xong mũi dạ dày mà không làm ảnh hưởng đến sinh khả dụng của thuốc. Thì đây là tóm tắt những xử trí rung nhĩ ở bệnh nhân Covid-19 theo khuyến cáo của Hiệp hội ESC năm 2020. Chúng ta để ý rằng ngoài việc đối phó với tình trạng rung nhĩ bằng kiểm soát các yếu tố khởi phát, sử dụng kháng đông, thì việc duy trì cái kali máu, magie máu là quan trọng. Và đặc biệt là ở trong cái nhóm bệnh nhân nhiễm Covid-19, người ta nói rằng nếu rối loạn chức năng thất trái mới xuất hiện thì mình nên cân nhắc đây là một cái dấu hiệu cho thấy tổn thương cơ tim của bệnh nhân đang diễn tiến, và về mặt điều trị Covid cần tăng bậc điều trị chức miễn dịch cho bệnh nhân. Một số ít bệnh nhân bị rối loạn nhịp thất. Tuy nhiên chúng tôi quan sát thấy những bệnh nhân này thường là những bệnh nhân nhiễm Covid rất là nặng nề, và y văn cũng cho thấy rối loạn nhịp thất nguy hiểm chiếm chỉ có 5,9% bệnh nhân nhiễm Covid-19 và thường xuất hiện hơn ở nhóm bệnh nhân có tăng troponin cao. Ngoài ra một cái điểm đặc biệt là y văn cũng cho chúng ta thấy rằng nhanh thất, rung thất trong cái bối cảnh nhiễm Covid-19 nặng nề là có thể là dấu hiệu của chỉ điểm của tổn thương cơ tim cấp nghiêm trọng do virus, và chúng ta cần leo thang điều trị ức chế miễn dịch và điều trị thuốc kháng virus để có thể khống chế tình trạng nhịp nhanh thất và rung thất này. Tuy nhiên thì một số bệnh nhân có sẵn bệnh tim nền trước đó thì tình trạng nhiễm Covid cũng có thể khởi phát lại nhanh thất trên cái bệnh tim nền mà bệnh nhân có thể không biết trước đó. Đối với một số bệnh nhân rối loạn nhịp thất nguy hiểm thì việc xử trí tại cơ sở của chúng tôi chỉ có thuốc như amiodarone và lidocaine mà thôi. Amiodarone thì hiệu quả hơn. Tuy nhiên một số bệnh nhân trước đó đã được điều trị ở trong cộng đồng bằng các thuốc như là hydroxychloroquine và azithromycin, một công thức bí ẩn ở ngoài cộng đồng, thì chúng tôi để ý có một số trường hợp QT dài. Những trường hợp này chỉ sử dụng lidocaine để điều trị nhịp nhanh thất mà thôi, bởi vì amiodarone khi phối hợp với hydroxychloroquine và azithromycin còn làm kéo dài cái đoạn QT của bệnh nhân. Thì việc điều trị chỉnh các yếu tố kích hoạt trong cái bối cảnh nhiễm Covid mà bị rối loạn nhịp cũng là một cái yếu tố hết sức quan trọng. Một số bệnh nhân có tình trạng thiếu oxy máu rất là nặng, giảm thể tích, đặc biệt giảm thể tích bởi vì bệnh nhân suy hô hấp, thở rất là nhiều, mà việc truyền dịch nếu mà không đủ sẽ dẫn đến là giảm thể tích rất là nặng nề, hạ kali máu, tăng trương lực giao cảm, và một số bệnh nhân bị tràn khí màng phổi thứ phát sau khi thở máy chúng tôi cũng gặp khi mà xử trí những cái rối loạn nhịp thất nguy hiểm. Thì đây là cái guideline khuyến cáo của Hiệp hội Tim mạch châu Âu về xử trí nhịp nhanh thất và rung thất ở bệnh nhân COVID-19. Thì ngoài những cái xử trí thông thường về rối loạn nhịp, thì bên guideline của ESC người ta cũng cân nhắc cho mình nếu bệnh nhân có những cái rối loạn nhịp nguy hiểm, nhanh thất, rung thất và kèm theo tổn thương thất trái nghiêm trọng, thì chúng ta cần cân nhắc đây là dấu hiệu của tổn thương cơ tim và tăng bậc điều trị ức chế miễn dịch, đồng thời cân nhắc sử dụng ECMO và phải loại trừ cái thiếu máu cơ tim, bởi vì một số bệnh nhân nhiễm COVID-19 gây tăng đông và kèm theo cái nhồi máu cơ tim mà chúng ta thường bỏ qua. Thì trước phần trình bày trước tôi đã nói về việc xử trí, những kinh nghiệm xử trí rối loạn nhịp ở bệnh nhân nhiễm COVID-19. Thế thì những bệnh nhân rối loạn nhịp mà không nhiễm COVID-19 chúng tôi đã xử trí như thế nào? Chúng tôi cập nhật những guideline trên thế giới và ứng dụng tại Việt Nam như thế nào? Thì khi cập nhật các guideline trên thế giới, chúng tôi thấy rằng đối với bệnh nhân mà rối loạn nhịp không mắc COVID-19, người ta phân loại ra làm thủ thuật rối loạn nhịp theo chương trình, thủ thuật bán cấp, thủ thuật khẩn cấp cứu để có thể xử trí. Những cái thủ thuật rối loạn nhịp theo chương trình sẽ được trì hoãn cho đến khi dịch Covid ổn định. Còn thủ thuật khẩn cấp cứu vẫn tiến hành làm với các phương tiện bảo vệ phòng hộ cho cả ekip, và thủ thuật bán cấp thì có làm hay không tùy theo đánh giá của thủ thuật viên và ekip chăm sóc y tế. Các thủ thuật chương trình như chúng ta đã biết, những cái bệnh nhân dù nhịp chậm với ít triệu chứng hoặc là thay máy ICD có pin máy còn hơn 6 tuần đều được chúng tôi trì hoãn lại cho đến khi mà dịch ổn định, và thực sự ra là cho đến khi bệnh nhân có thể đi lại được. Bởi vì thực tế là chỉ thị 15, 16 với rất là nhiều chốt gác tại thành phố Hồ Chí Minh và các tỉnh lân cận làm cho việc đi lại của bệnh nhân rất khó khăn. Bệnh nhân thậm chí không thể đi ra từ cái khu phố của mình. Đây là những cái thủ thuật bán cấp mà chúng tôi cần phải cân nhắc, như là những thay máy tạo nhịp ở bệnh nhân mà có pin đặt tới ngưỡng, mặc dù là tới ngưỡng ERI, mặc dù trên guideline khuyến cáo là những cái thủ thuật này có thể trì hoãn, nhưng mà tuy nhiên cũng phải cân nhắc cái triệu chứng của bệnh nhân và tỷ lệ lệ thuộc máy để xác nhận là bệnh nhân có thể trì hoãn hay không. Các thủ thuật khẩn và cấp cứu như bệnh nhân nhịp chậm lệ thuộc máy cần phải thay máy, hay là máy tạo nhịp của bệnh nhân đã cán tới cột mốc end of life thì cũng cần phải thay khẩn và cấp cứu, bất chấp là chúng ta đang ở chỉ thị 15 hay 16. Và một số bệnh nhân rất là không may mắn là mang máy và lại bị nhiễm trùng máy trong cái đợt giãn cách xã hội, thì chúng tôi phải tìm cách để đưa bệnh nhân đến bệnh viện thông qua các chốt để giúp bệnh nhân đến bệnh viện truyền kháng sinh và xử trí những cái nhiễm trùng máy. Thì cái việc mà có hai việc mà chúng tôi làm trong cái đại dịch, thứ nhất là phải xác định cái thủ thuật của chúng ta có khẩn cấp hay không, và sau đó một cái điều khó khăn không kém đó là tìm cách để đưa bệnh nhân đến được cái cơ sở y tế của mình. Bởi vì khi mà chốt ở khắp nơi thì việc bệnh nhân di chuyển rất là khó khăn, cần phải đủ giấy tờ, và việc có đủ giấy tờ hay không chúng tôi thực sự ra là phải giúp bệnh nhân rất là nhiều, làm những cái giấy đóng mộc đỏ rồi chụp qua Zalo để bệnh nhân có thể trình để đi qua chốt. Thì đây là tình hình thực tế của chúng tôi ở giai đoạn cao điểm của Covid-19 tại thành phố Hồ Chí Minh vào tháng 7, tháng 8 và tháng 9. Thì tình hình là giãn cách xã hội nghiêm ngặt, người dân thực sự là không được ra ngoài khi không thực sự không cần thiết. Thế thì khi nào là không thực sự cần thiết? Điều này vấp phải rất là nhiều cái phản ánh. Người dân đi ra ngoài mua lương thực không được, người dân cũng không có thể nào tiếp cận y tế, bởi vì cái người trực chốt đó, đôi khi người ta tuân thủ mệnh lệnh hành chánh một cách nghiêm ngặt, do đó bệnh nhân cũng không thể nào tiếp cận được bệnh viện. Thì chúng tôi phải giúp đỡ bệnh nhân thông qua điện thoại, thông qua giấy tờ. Và việc trong những cái tháng giãn cách xã hội đó, chúng tôi đã theo chính sách của bệnh viện là sử dụng hotline. Bệnh viện cấp 30 số tư vấn các chuyên khoa, 30 chuyên khoa. Thì chuyên khoa rối loạn nhịp của chúng tôi cũng được một cái số hotline, và những cái ngày ấy là những ngày không thể quên được đối với ekip của chúng tôi, bởi vì điện thoại reng liên tục. Và thay vì một ban đầu là cho mỗi bác sĩ trực một ngày, sau đó là phải đôi khi có những cái ngày mà công việc rất là dồn dập thì chúng tôi phải thay thế 2 bác sĩ trong một ngày để có thể bác sĩ có thể thở được trước khi trả lời câu trả lời tiếp theo. Thì thực sự khi chúng tôi tư vấn thì chúng tôi phát hiện là có rất là nhiều vấn đề, mà đặc biệt là vấn đề liên quan đến thuốc kháng đông. Thuốc kháng đông, nếu như bệnh nhân nào đang uống thuốc kháng đông là thuốc antivitamin K, thực sự rất là khó khăn, bởi vì người ta cũng không thể nào đi kiểm tra INE và làm thế nào để chúng ta chỉnh thuốc cho bệnh nhân. Về thuốc kháng đông được uống thế hệ mới thì trong cái đại dịch tháng 7, tháng 8, tháng 9 thì cái cái công văn của thành phố là cho phép sử dụng Xarelto và Bradasa trong các phác đồ mà phòng ngừa huyết khối ở bệnh nhân COVID. Thế là sau công văn đó thì bệnh nhân không thể tìm ra được kháng đông, đường uống nữa. Những cái thuốc này đã được sử dụng để điều trị bệnh nhân COVID, đã được các nhà tài trợ, các nhà từ thiện gom thuốc để phục vụ cho những cái khu mà điều trị COVID đặc biệt, bởi vì cho thấy là bệnh nhân ở những cái khu thường không thể nào tìm được cái thuốc kháng đông, mà nếu tìm được thì cái giá cũng là có thể tăng lên gấp rưỡi và bệnh nhân buộc lòng phải trả tiền để mua các thuốc này. Ngoài ra khi chúng tôi tư vấn thì các vấn đề liên quan đến máy tạo nhịp ICD như bệnh nhân nói đã đến hẹn tái khám, làm thế nào bây giờ bác sĩ, thì chúng tôi đành phải nói không yên tâm, không sao đâu, chúng ta phải đợi dịch qua rồi mới đi tư vấn được. Chúng tôi tư vấn các vấn đề liên quan đến nhịp nhanh thì buộc lòng tất cả đều được điều trị bằng thuốc. Tuy nhiên việc tìm ra những cái thuốc cortisol hay là ức chế beta trong cái giai đoạn này không phải là một cái điều dễ dàng đối với bệnh nhân. Và điểm đặc biệt là khi cái quá trình tư vấn chúng tôi phát hiện ra đó, bệnh nhân sau khi mắc Covid đó, có thể có những cái vấn đề về nhịp nhanh xoang hoặc ngại tâm thu, hoặc là những cái ca bệnh nhân sau khi mắc người ta bị rối loạn tâm lý vô tình trạng lo lắng quá mức, cũng có thể là nguyên nhân gây ra nhịp nhanh xoang, ngoại tâm thu mà sau này được gom vào cái hội chứng gọi là hậu Covid. Và trong quá trình tư vấn điện thoại đó, chúng tôi buộc lòng phải sử dụng Zalo để xem triệu chứng của bệnh nhân như thế nào, để xem bệnh nhân gửi những cái hình ảnh về thuốc men đang sử dụng ra sao. Thì cái quá trình tư vấn rối loạn nhịp qua điện thoại được hỗ trợ bởi nếu bệnh nhân có máy đo huyết áp ở nhà, chúng tôi hỏi về những cái thông số nhịp tim và huyết áp ở nhà để tư vấn. Thì ngoài ra qua quá trình đó chúng tôi phát hiện rằng có một số cái thiết bị thông thường mà sử dụng hàng ngày như Apple Watch có thể phát hiện các trường hợp nhịp nhanh, nhịp chậm, và qua đó chúng tôi có thể phát hiện được trường hợp nhịp chậm do suy nút xoang, hoặc là bệnh nhân báo là nhịp của tôi chỉ có 34 lần một phút thôi bác sĩ. Thì thật ra đó là những cái trường hợp ngoại tâm thu thất nhịp đôi, và chúng tôi phải hỗ trợ bệnh nhân vượt chốt để đến bệnh viện thăm khám. Thì việc hỗ trợ vượt chốt cũng không phải là một cái điều dễ dàng. Thì đây là một cái câu chuyện mà chúng tôi muốn thuật lại, đó là có một bệnh nhân nữ 24 tuổi đặt máy tạo nhịp 2 buồng 4 năm. Sau khi trong cái bụng bi lăng, sau khi phát hiện được động kinh của bệnh nhân, sau khi đặt máy rồi thì bệnh nhân hết động kinh, bệnh nhân được tiêm ngừa vaccine Covid mũi 1. Thì sau khi mũi 1 thì bệnh nhân động kinh một lần, nhưng mà tuy nhiên họ vẫn nghĩ là có lẽ là do cái vaccine gây ra cái cơn động kinh, và đồng thời họ nghĩ là trước đây cũng có động kinh nhưng mà sau đó hết, nhưng họ không có gì hoảng loạn hết. Sau đó do cái tình hình dịch trước đây á, nếu mà bệnh nhân tiêm vaccine có triệu chứng gì thì họ sẽ từ chối tiêm mũi 2. Tuy nhiên như quý thầy cô và anh chị đã biết thì sau đó thành phố Hồ Chí Minh có đợt là mọi người phải tiêm 2 mũi mới có thẻ xanh, mới có thể ra đường. Thế là bệnh nhân cũng bấm bụng đi tiêm mũi 2 mặc dù trước đó đã bị cơn động kinh sau khi tiêm mũi 1 rồi. Thế bệnh nhân cũng tiêm mũi 2, sau tiêm mũi 2 thì các cơn động kinh có vẻ tái đi tái lại nhiều lần hơn. Và sau đó bệnh nhân là quyết định là phải đi khám nội thần kinh. Thì khi bệnh nhân đi khám nội thần kinh á, thì bác sĩ nội thần kinh nói phải đi khám máy. Thì khi khám máy thì chúng tôi phát hiện là bệnh nhân máy đã đạt đến tình trạng là end of life luôn, và nó chỉ kích thích một cách rất là chập chờn. Do đó bệnh nhân được hỗ trợ nhập viện khẩn cấp để thay máy tạo nhịp vĩnh viễn cho bệnh nhân. Ngoài ra có một số trường hợp là nhiễm trùng máy cũng rất là khó khăn đi đưa bệnh nhân đến bệnh viện, vượt các chốt để đưa bệnh nhân đến bệnh viện. Thế thì rõ ràng là qua cái đợt dịch Covid vừa qua tại thành phố Hồ Chí Minh, chúng tôi đã thay đổi cái phương pháp điều trị của bệnh nhân từ thăm khám trực tiếp thành chuyển sang khám từ xa. Thế chúng tôi sẽ tham khảo những cái thiết bị giúp chúng tôi quản lý bệnh nhân với thiết bị theo dõi từ xa. Thì chúng tôi cập nhật một số mục tiêu của tim mạch học từ xa, đó là gì? Đó là giảm áp lực cho hệ thống chăm sóc sức khỏe. Thì hơn ai hết qua cái đợt dịch này thì chúng tôi thấy rằng là việc giảm áp lực cho hệ thống chăm sóc sức khỏe cực kỳ quan trọng. Và cái việc mà tim mạch học từ xa giúp chúng tôi có thể theo dõi bệnh nhân ở vùng sâu, vùng xa và đưa ra các can thiệp đặc thù sớm. Chẳng hạn nếu như mà em gái 24 tuổi bị động kinh đó, chúng tôi có thể theo dõi máy từ xa thì có thể phát hiện được đây là một trường hợp hết pin sớm, và chúng ta cần phải đưa bệnh nhân đến bệnh viện sớm hơn để tránh có bệnh nhân có những cái cơn động kinh tái đi tái lại nhiều lần. Qua đó giảm được tử vong, giảm thiệt hại về chức năng và cũng là tiết kiệm được cho bệnh nhân. Thì khi theo dõi y văn, chúng ta thấy rằng chẩn đoán tim mạch từ xa đã được phát triển từ vài năm qua bằng các thiết bị như đơn giản nhất là iWatch để phát hiện rung nhĩ, hay là những cái máy tạo nhịp được gắn vào bệnh nhân cũng có thể theo dõi từ xa qua các thiết bị như là Bluetooth hoặc là những cái Wi-Fi để đưa cái thông tin đó về máy chủ, và qua đó là bác sĩ sẽ theo dõi những cái thông tin này và đưa ra những cái quyết định điều trị sớm nhất cho bệnh nhân. Thì chúng tôi nhận thấy rằng cái việc truyền dữ liệu qua các tín hiệu từ xa này nó khá là chuẩn xác, rõ nét, có thể phát hiện được những cái nhịp nhanh trên thất được kích thích ATP thành công, hoặc là những cái cơn rung nhĩ mới phát hiện, hoặc là nhịp nhanh thất, hoặc là những cái trường hợp mà do sensing quá mức, do những cái tín hiệu nhiễu dẫn đến máy được chẩn đoán là rung thất. Thì chúng tôi có thể, nếu như nhận được những cái tín hiệu như thế này, chúng tôi có thể gọi điện thoại cho bệnh nhân, yêu cầu bệnh nhân đến bệnh viện sớm hơn để được xử trí. Ngoài ra, đối với những cái bệnh nhân suy tim thì các thiết bị trên thế giới như những cái sensor đo áp lực động mạch phổi cũng có thể giúp chúng ta triệu tập được bệnh nhân sớm hơn, hoặc là gửi thông tin về cho bệnh nhân uống thêm thuốc lợi tiểu, giúp cho bệnh nhân qua cái cơn phù phổi cấp hoặc là đợt cấp của suy tim. Thì ngoài các thiết bị mà được cấy vào cơ thể thì các thiết bị mà không cấy vào cơ thể cũng giúp chúng ta theo dõi từ xa, như máy đo đường huyết tại giường tại chỗ, hoặc là máy đo INE tại chỗ. Chúng tôi thấy rằng cái máy này cực kỳ tiện lợi trong quá trình theo dõi từ xa. Tuy nhiên trước đây chúng ta không quan tâm bởi vì giá thành của nó. Thì qua cái đợt dịch này thì chúng tôi đã có một số tư vấn cho các bệnh nhân có điều kiện thì đang điều trị bằng thuốc kháng đông AVK, thì mua cái máy này để có thể liên lạc với bác sĩ và tự test tại nhà để chúng tôi có thể điều chỉnh thuốc qua điện thoại. Ngoài ra, một số cái thiết bị hiện đại như là Apple Watch cũng giúp chúng ta có thể theo dõi nhịp tim của bệnh nhân, chẩn đoán rung nhĩ và có với một cái thông tin về điện tâm đồ tương đối khá là đẹp cho bệnh nhân. Tuy nhiên, tất cả những theo dõi từ xa đó muốn trở thành hiện thực tại Việt Nam sẽ trải qua rất là nhiều bước. Bước về quản lý hành chánh, liệu Bộ Y tế có chấp nhận các thiết bị này lưu hành trên thị trường hay không? Liệu về mặt tổ chức chúng ta có thể tổ chức cho nhân sự theo dõi các thiết bị này 24/7 hay không? Và liệu việc chi trả sẽ được bảo hiểm thanh toán như thế nào? Đó là một cái chặng đường dài cần phải được nghĩ đến và xúc tiến để một ngày nào đó sẽ trở thành hiện thực, và hy vọng sẽ giúp được bác sĩ của chúng ta quản lý bệnh nhân tốt hơn. Xin cảm ơn sự theo dõi của quý thầy cô và quý anh chị đồng nghiệp.
Vâng, xin cảm ơn phần trình bày rất hay của Thạc sĩ Trần Lê Uyên Phương, là một người trong cuộc đã trải qua một đợt dịch Covid-19 hết sức nặng nề tại Thành phố Hồ Chí Minh, và cái đợt dịch đó cũng cho thấy sự cấp thiết làm chúng ta phải thay đổi cách thực hành truyền thống, chuyển sang những phương thức theo dõi từ xa, và cũng một đợt tập dượt ban đầu cho việc ứng dụng những công nghệ theo dõi từ xa ngày càng phổ biến và rộng khắp trên toàn mọi hoàn cảnh thực hành rối loạn nhịp tim tại Việt Nam chúng ta. Và để đảm bảo cái tiến độ về thời gian, xin cảm ơn Thạc sĩ Trần Lê Phương. Chúng ta sẽ bước sang phần trình bày thứ hai. Chúng ta cùng xem một cái video clip thu sẵn phần trình bày của tiến sĩ Janina Liu đến từ Singapore và đã có phần dịch song song. Các bạn có thể lựa chọn ngôn ngữ tiếng Việt. We'd like to invite the presentation of Dr. Janina Liu from the Harley Street Heart Center of Singapore, please.
Thank you. Share my screen. Great. Thank you very much for the kind invitation to give this presentation. It's an honor to be part of this symposium. So I think my talk very nicely follows on from the last presentation. I'll be talking about the remote monitoring of arrhythmia patients from elective to essential. And as I'm sure many of you have seen during the COVID pandemic, many patients have been reluctant or worried about coming to clinic or hospital to see patients, to see doctors. And therefore, doctors and hospitals need to adapt in order to continue to monitor our patients effectively, but at the same time, try to limit the number of unnecessary clinical hospital visits to protect patients. So many of you, I'm sure, have patients with pacemakers and devices. And the conventional way that we monitor patients are to see them every 3 months or sometimes longer in clinic to check them and see if we can pick up any abnormalities or make any changes. But many of the times these visits do not result in any changes, and therefore a lot of them are probably unnecessary, but take up a lot of valuable clinic time and clinic resources. So the whole point of remote monitoring is that it allows a more centralized rapid processing of patient data and allows identification of patients who may actually need something done about their devices without them coming regularly to clinic for routine follow-up. The system here, for example, will pick up the patient that has an abnormality from their remote monitoring parameters, and then that will allow the doctor to contact the patient as necessary and make appropriate changes, rather than see all the other patients that may not have any abnormalities and may not need to have a remote, an in-clinic visits. And the system allows the data from the monitoring platform to store the information in a cloud-based system and then send the information to the doctor. The important point about any remote monitoring platform is that it is automatic. In other words, the patient doesn't need to do anything, and the doctor or hospital doesn't need to do anything either in order to obtain the information. So it doesn't require any action from the patient or the doctor unless they wish to do something. It needs to be reliable and allow for daily transmissions without any battery drain. And importantly, it has to allow the notification of abnormalities to the doctor, even if the patient is asymptomatic. All of the major device companies have their own remote monitoring system. And importantly, a lot of data now has shown that these systems simplify device follow-up and also improve patient safety because they alert the physician to any early changes in the device function or in the patient's clinical parameters. For example, as we heard in the last speaker, the systems can sometimes detect a new onset or worsening atrial fibrillation or worsening heart failure and allow the doctor to take actions to treat that accordingly. So a number of important studies have been investigated in this field. And this is one of the important studies, the TRUST study published in Circulation in 2010. This was a randomized prospective multi-center trial of remote monitoring versus conventional care in ICD patients who are not patient dependent. The study looked at 1,339 patients, and they were randomized in a 2-to-1 fashion to remote monitoring or conventional follow-up. And the patients were seen in clinic at 3, 6, 9, and 12 months. And those that were in the home monitoring group were seen at 3 and 15 months. And in between visits as required. An important of this study was that it found the patients in the home monitoring group had reduced total in-hospital device evaluations compared by 45% compared with the conventional monitoring group. But this did not affect the morbidity or the survival of the patients. And the median time to evaluation of any abnormality from the system was 2 days in a home monitoring group, compared with 36 days in the conventional group for all arrhythmic events. This is some of the summary slides from that study showing, you can see the remote monitoring group in dark line on this graph had markedly fewer outpatient visits compared to the conventional group over the period of the follow-up. And this increasingly diverged after 120 days. And the patients in a remote monitoring group had fewer scheduled office visits, as you would expect. But of course, the times that they did go to the clinic was because they were called back because an abnormality was detected. And so these were appropriate follow-up visits because of a detection. But overall, the important point is that remote monitoring reduces the number of unnecessary clinic visits. And as mentioned, there was no significant difference in the safety between conventional and home-based monitoring. This is a summary slide showing in the TRUST study the number of different arrhythmias that were detected earlier in the remote monitoring group compared with the conventional group. So both patients with atrial fibrillation, ventricular arrhythmias, and SVTs had much earlier onset of evaluation and detection compared with the conventional group. And that included both patients with symptoms and also silent arrhythmias. And that's one of the big advantages, in my view, of remote monitoring. You can pick up asymptomatic arrhythmias earlier and prompt action from the doctor. So one example is the delay between arrhythmic events and the medical diagnosis and treatments was reduced from 36 days to 1 day for ventricular fibrillation and from 28 days to 1 day for ventricular tachycardia in the remote monitoring group. So the conclusion of the study was that home monitoring is safe, allows for more rapid detection of actionable events compared with conventional monitoring in patients with implantable electronic cardiac devices. Another important study published 2011 in JACC was a CONNECT study. That was a randomized prospective multicenter study of almost 2,000 patients with ICDs and CRT-D devices. And the main purpose was to determine if remote monitoring using a wireless platform with automatic clinician alert reduces the time from a clinical event picked up by the remote monitoring system to a clinical decision decided by the doctor in response to the data detected. And the main finding was that there was a reduction in the median time from the clinical event to the actual clinical decision from 22 days in in-office patients to 4.6 days in a remote monitoring pick up abnormalities and arrhythmias earlier, but it also led to action by the doctor to actually improve the patient care. This is a summary slide from the HRS expert consensus statement in 2015, again summarizing the fact that remote monitoring reduces in visits to the clinic to see the doctor, remote monitoring blue, conventional in red. It reduces the onset of evaluation for all arrhythmias, but also the asymptomatic silent arrhythmias. And also it reduces the number of patients missed to follow-up because there's improved compliance since the patients don't need to come as frequently to see the doctor in their clinic. There have been 2 large registry studies that have shown an improved survival in the patients on remote monitoring compared with conventional follow-up. Note, these are not randomized studies, but registry studies, but nonetheless, I think it's very useful and important that we have some data to show potentially improved survival with the remote monitoring group. The Altitude study showed that patients with ICDs followed with remote monitoring had a better outcome in terms of survival compared with patients on follow-up in the office. And similarly, the Merlin group showed a similar result. These were patients in the Merlin group with devices, pacemakers, ICDs, and CRT-Ds. And again, there was an improved survival in the remote monitoring group. This is again a summary slide showing data from these 2 big studies. The ICD group with remote monitoring had improved survival compared with the ICD group without home monitoring. And the CRT network group also had improved survival compared with the CRT non-network group over the follow-up of 5 years. So in view of all these different studies, they have prompted the HRS consensus statement in 2015 to recommend remote monitoring as a class 1 indication for these groups of patients. So for patients that need regular surveillance of lead function and battery conservation, for patients that may have a device that is on recall or on advisory and need to be monitored more frequently for any detection of early actionable events, remote monitoring class 1 indication for patients with inappropriate ICD shocks, and class 1 indication for the early detection and quantification of atrial fibrillation. Of course, some of us use remote monitoring to check for thoracic impedance and worsening of heart failure symptoms. That's very useful clinically. Currently, it's been given a class 2B indication because there hasn't been very clear, strong evidence long-term for this use, but nonetheless, it's very useful clinically to check for heart failure and worsening symptoms. But I think the important point is that clinicians now should recognize that remote monitoring of patients with cardiac implantable electronic devices should now be the standard of care. Better detection of arrhythmias leading to early action by the doctor, and also increasing evidence that suggests improved survival in patients that have remote monitoring. Some definitions on the terms that we use. Remote follow-up is just scheduled routine follow-up electronically from downloads from their device rather than routine follow-up in clinic. And these can be done at rarest times, such as every 3 months. Whereas remote monitoring is different from remote follow-up. It involves the regular daily check, automatic check of the patient's device parameters by the remote monitoring platform that will then alert the doctor to any abnormalities. So for example, high lead impedance, new atrial fibrillation, the doctor will be alerted automatically without any routine action taken by the doctor to check the patients. Possible future of remote care is remote programming, whereby the doctor may be able to actually make changes to the patient's device parameters, although this has yet to be realized, and there are a number of ethical and security issues if we're going to start to make changes to patients' programming. So this is one example of a remote monitoring system, the Merlin network that's used by the Abbott devices. It is a secure internet-based system that connects the patient to the physicians outside of the clinic setting. The system uses a centralized data from remote transmissions and implant procedures and allows all the information from that patient to be centralized into an electronic health record that can be exported easily to the doctor's EHR system. And the data is kept in the system for a minimum of 7 years. This is how it works. There's a centralized cloud-based server that will collate all the information from patients with those devices from that particular company. And the patient will be given a transmitter that can transmit to the centralized cloud-based system. So after the patient has a device inserted, he or she will be taught how to use the system and how to transmit and upload data into that centralized server. That centralized server will collate the patient's information and can send the information to the electronic health record for that patient and the system for the doctor that's looking after the patient. The system is manned 24/7 by a centralized call center and a technical support. So if the patient has any specific questions, he or she can contact the technical support. And the important point is that this centralized cloud-based system will communicate with the physician and the patient if any important abnormalities are detected, or routinely communicate with the physician just to inform the physician of the patient's device parameters. The patient can upload information as required onto the system, and the physician can look at the information based on that patient's data. The radio frequency transmitter allows for the scheduled follow-up and data to be sent and retrieved without patient involvement using an analog phone or cellular network. And the physician can decide how he or she wishes to receive information from the platform via email, fax, SMS, to the physician directly. And as mentioned, the patient can also upload information if directed to by the physician, or if the patient has any symptoms that they're worried about and wanted the physician to check the device in between the routine scheduled uploads from the system. So the doctor will receive periodic notification from the system automatically, and that importantly allows the physician to monitor the patient more carefully without any action needed from the physician routinely. It allows the doctor to pick up critical device issues between scheduled follow-ups, and that's how we can improve survival of patients using this feature. It allows for better and enhanced patient care with more timely interventions. And also importantly for my patients that have remote monitoring, they also have peace of mind because they often feel that even when they're not seeing a doctor, they have the confidence that the doctor or the clinic is continuously monitoring their data and will contact them if any abnormality is detected. So the important message is that the system will deliver information in a timely and appropriate care to the doctor in between scheduled visits, and the patient has peace of mind to know that they are being monitored more carefully and more frequently. As mentioned, the doctor, it's quite easy to use the system. Once they have their own login, they can actually make changes to decide how they wish to receive alerts and what type of alerts they wish to receive. So the doctor may want to tick red or yellow alert classification for certain device function. For example, if the doctor knows the patient is approaching the end of life for their battery, they may want to receive more regular updates on the device battery follow-up. They may also want to receive information on the clinical parameters of the patient based on the remote monitoring data. So they may want to receive information on atrial fibrillation episodes or ventricular arrhythmia episodes, and then contact the patient to make further clinical changes. And increasingly, we now have data to show that if there's better patient engagement with their own care, they will have better outcomes. They will ultimately reduce hospitalization because they also feel more confident that they'll be monitored, and there'll be reduced mortality rates among patients. Many of these systems now have smartphone application that allows patients to actually connect to the system via their smartphone, and they can send data manually. They can also assess their own device battery status. They can look at the history of their transmissions, and also there's some technical support on the system that they can contact if they need further information. And this is an example of how easy it is for patients to send their own information via their smartphone application. They can also check their own device battery left if they're worried that it's approaching end of life, rather than contact clinic or feel that they're worried that the device may stop without them realizing it. So in summary, I'd like to just make these 4 points. Remote monitoring in patients with cardiac implantable devices is now the standard of care and should be offered to all patients. The remote monitoring platforms have been shown to allow for earlier detection of arrhythmias such as worsening atrial fibrillation or heart failure or lead fractures. It reduces the time to clinical decision making and improves patient compliance and retention. And also important registry data has suggested improved survival in patients on remote monitoring compared with conventional follow-up. Remote monitoring reduces in-clinic visits, thereby improving patient compliance, but also reducing clinic slots for other patients who may need to see the doctor more urgently. And increasingly, remote monitoring can be performed via the patient's smartphone apps to allow for easier use of the devices. So with that, I'd like to thank you for your attention and thank the chairman for the kind introduction. Thank you.
Many thanks for Dr. Regina Liu from Singapore for your very sensual presentation in terms of remote monitoring of pacemakers. And before we're moving on to the next speakers, we'd like to ask you one question. Could you share with us the real practice in Singapore in terms of remote monitoring of CIDs? How many percent of patients living with that? Thank you.
Yes, thank you. Yes, that's a good question. I would have loved to share some more clinical examples if we had more time, but it's a good question. I can just share with you some examples. Well, first of all, I would say that probably over 90% of our patients with devices are on remote monitoring in Singapore. Even though Singapore is a small island and patients can come to see doctors easily, they still prefer to be monitored remotely. I mean, one recent example is I had a patient who has heart failure with CRT-D device, but not known to have atrial fibrillation. And the device basically picked up new onset asymptomatic atrial fibrillation, which, as you know, is quite dangerous and increased risk of stroke in patients with heart failure. So I was able to contact this patient earlier, within 1 or 2 days of picking up the AF. We contacted the patients, asked them to come back to clinic. We talked to them about the benefits of anticoagulation, and we started anticoagulation. So that's in comparison to the previous system, whereby you'd have to wait to the next follow-up period, which may be 3 months later. And in that scenario, there may be at risk of a stroke if you wait another fibrillation.
Thank you. Và kính thưa quý vị, là chúng tôi có hỏi bác sĩ Liu là vậy thì thực tiễn sử dụng hệ thống theo dõi từ xa tại Singapore như thế nào? Thì bác sĩ Liu nói rằng là mặc dù Singapore là một quốc đảo tương đối nhỏ, nhưng mà 90% các bệnh nhân mang máy tạo nhịp tim ở đó đã được theo dõi bằng công nghệ từ xa để hạn chế cái việc là để có thể nhanh chóng phát hiện được. Và ông cũng đưa ra một cái ví dụ là một bệnh nhân suy tim đang có một thiết bị tạo nhịp và đã sớm phát hiện những cơn rung nhĩ, và do vậy thì các bác sĩ trong vòng một vài ngày đã tiếp cận bệnh nhân, xử trí cắt cơn và đặc biệt điều trị chống đông cho họ. Vì nếu như theo lối theo dõi truyền thống thì người bệnh gặp bác sĩ sau vài tháng và có thể họ đã bị một cái đột quỵ vì rung nhĩ trên nền suy tim, và đương nhiên là không kiểm soát rung nhĩ thì có thể làm suy tim còn nặng hơn nữa. Thank you very much for your comments on that very important problem, and thank you, and we will move to the next speakers. Và người tiếp theo, speaker tiếp theo, tôi xin trân trọng giới thiệu một bác sĩ cũng rất là nổi bật trong Thành phố Hồ Chí Minh về lĩnh vực điện sinh lý tim và tạo nhịp, bác sĩ Đỗ Văn Bửu Đan đến từ Bệnh viện Tim Tâm Đức, và xin mời trình bày về chủ đề tác động mạnh mẽ của công nghệ theo dõi bệnh nhân từ xa trong tương lai. Xin chào kính mời bác sĩ Đỗ Văn Bửu Đan.
Dạ, xin cảm ơn tiến sĩ Phan Đình Phong. Xin kính chào chủ tọa đoàn cùng các bạn đồng nghiệp. Thì cái bài của Dr. Regina Liu cũng khá là chi tiết về cái việc theo dõi từ xa. Bài báo cáo chúng tôi xin được sẽ có một vài phần trùng lắp, tuy nhiên tôi cũng xin trình bày một số cái điểm có lẽ cũng thực tế để cho các bạn đồng nghiệp tham khảo. Thì cái ngày nay cái công nghệ theo dõi từ xa nó tham gia vào tất cả các quá trình của chăm sóc sức khỏe, đặc biệt trong cái bài báo cáo của bác sĩ Yên Phương chúng ta thấy đặc biệt trong cái thời đại Covid thì cái vai trò của công nghệ từ xa nó lại càng nổi bật và rất là cần thiết. Ngày trước thì chúng ta coi như là cái việc đó là để cho sophisticated, cho vui thôi, nhưng mà ngày nay thì cái vai trò nó là không thể thiếu, và đặc biệt là khi có những cái hoàn cảnh đặc biệt như bệnh nhân xa, đại dịch, thì cái việc áp dụng nó lại mang rất là nhiều ích cho bệnh nhân. Thì đây là vài cái vấn đề chúng tôi thực tế có lẽ tất cả chúng ta đều gặp mà rất là thú vị. Ở ngoài cái lĩnh vực tim mạch thì những cái bệnh khác, như là thậm chí là trong cái đợt dịch này người ta ghi nhận là những cái người mắc bệnh đường tình dục thậm chí là cũng không có đi khám những cái bệnh rất là đơn giản mà cần thiết, không đi khám, để lúc mà nặng quá lại đi khám thì gây ra những biến chứng ảnh hưởng đến cái sinh sản. Trẻ em cũng vậy, trẻ em thì cứ bị bệnh mà không có dám đến bệnh viện bị dịch, và để cái bệnh từ nhẹ đến nặng, các em bị nhiễm trùng hấp trên thôi, sau đó không điều trị thì qua hấp dưới, thậm chí là đến có thể là tử vong. Thì cũng tương tự vậy, trong cái lĩnh vực tạo nhịp thì chúng ta đã gặp những cái báo cáo mà có lẽ thì lâu rồi chúng ta không gặp. Nên là hồi xưa thì chúng ta biết là do cái quá trình theo dõi không có kỹ, thì có những bệnh nhân có thể là mang cái máy và không được kiểm tra, rồi sau đó bị máy nó bị viêm, nhiễm trùng, hoặc là da mỏng quá nó lòi ra ngoài. Thì ngày nay hầu như chúng ta không thấy, hoặc là rất là hiếm thấy. Thì trong quá trình Covid thì lại có những báo cáo xuất hiện trở lại là do bệnh nhân có tình trạng đỏ da, nhiễm trùng, không đi khám, đến lúc mà máy chui ra ngoài. Thì để chia sẻ với các bạn không phải trong lĩnh vực tạo nhịp, chúng ta cũng biết thêm là cái máy tạo nhịp khi mà chúng ta cấy vào người, nếu mà nó chỉ có bị đỏ đỏ, chúng ta mở ra, chúng ta nhét sâu vào làm sạch thì có thể là không cần phải bỏ. Khi mà cái máy nó đã chui ra ngoài như trên hình bên phải như thế này thì được coi là đã nhiễm trùng toàn bộ hệ thống, và khi đến với chúng tôi là phải bỏ. Thì để dễ hiểu, nếu mà cái máy tạo nhịp thì một buồng như thế này thì cái chi phí không cao. Tuy nhiên tưởng tượng nếu chúng ta có cái máy ICD hoặc CRT-D thì chi phí nó lên tới vài chục ngàn đô la, thì cái chuyện đó nó là trở nên rất là nghiêm trọng. Thì theo có nhiều nghiên cứu thì có một cái báo cáo ở một cái trung tâm thì người ta đánh giá cái việc theo dõi của bệnh nhân đang mắc nhịp có bị ảnh hưởng như thế nào bởi quá trình Covid. Thì trong cái quá trình Covid này thì người ta nhận thấy là chỉ có khoảng 30% bệnh nhân là đến theo cái khám định kỳ thôi, tức là cái tỷ lệ đi tái khám để kiểm tra máy rất là thấp. Và chính vì vậy đưa đến cái chuyện là có những bệnh nhân có bị vấn đề mà không có được xử trí kịp thời. Trong khi trong số đó là chỉ có khoảng 14% bệnh nhân ở đi khám thường xuyên thì mới được là kiểm tra máy và làm cái chuyện lập trình, chỉnh lập trình hoặc là điều chỉnh thuốc cho phù hợp, thậm chí là nhập viện. Thì như Dr. Liêu có trình bày, cái hệ thống này là cái hệ thống theo dõi tại nhà, Telehome Monitoring. Thì thực ra cái hệ thống này nó không có mới, nó đã có nhiều năm nay rồi. Tuy nhiên là nó ở Việt Nam, đặc biệt là Việt Nam thì chưa có đi vào thực tiễn sử dụng do những vấn đề liên quan như là chi phí, những vấn đề theo dõi, phải có cái hệ thống theo dõi. Thì cũng rất là thú vị khi bác sĩ Phong hỏi, tiến sĩ Phong hỏi cái thông tin thực tế ở bên Singapore, thì ông nói là tới 90% bệnh nhân là cấy được có cái hệ thống theo dõi này. Thì tôi nghĩ rất là hữu ích, bởi vì bên đó là đảo nhỏ mà người ta lại muốn đi theo dõi thường xuyên. Thì những cái công ty máy thì hầu hết thì đều có những cái hệ thống riêng. Đây là cái hệ thống Merlin của công ty Abbott, trước là Senjit. Thì cái hệ thống này nó bản chất của nó là gì, là cũng xin nói rõ, đây là một cái máy nó phát radio frequency, cái tần số sóng, nó sẽ thu thập cái tín hiệu từ máy tạo nhịp bệnh nhân và nó gửi qua, có thể là qua điện thoại hoặc là qua mạng wifi để gửi tín hiệu về một cái trung tâm. Từ trung tâm đó người ta sẽ phân tích những cái dữ liệu từ máy tạo nhịp của bệnh nhân, thay vì bình thường là bệnh nhân phải đến bệnh viện để kiểm tra bằng cái programmer. Thì cái việc này thực hiện nhiều năm nay rồi, nó nhờ vậy người ta có thể giảm cái số lần kiểm tra máy tại phòng khám. Thì có lẽ ở Việt Nam, đặc biệt là chẳng hạn như thành phố Hồ Chí Minh hoặc Hà Nội, thì chúng ta ít thấy cái lợi ích như ở nước ngoài, thì do những cái nơi nó xa, phải đi xa hơi rất là xa. Thì chỉ cần ví dụ thay vì bình thường là một năm kiểm tra 4 lần thì giờ còn 1 lần, thì người ta cũng rất là vui rồi. Ngoài ra nó giúp cho chúng ta có thể theo dõi, giám sát hàng ngày nữa, tức là không chỉ là theo từng đợt kiểm tra mà theo dõi cái thông tin liên tục. Nếu mà máy có những cái báo động warning nào thì chúng ta có thể xử trí rất là kịp thời. Thì những cái warning đó là nó sẽ có những cái việc, thứ nhất là nó theo dõi những cái chỉ số về cái kháng trở, về cái nhận cảm, cũng như là những cái thích của bệnh nhân, và có cái gì lạ thì hoặc là thay đổi đột ngột thì sẽ báo. Và ngoài ra nó có thể theo dõi được những cái tình trạng bệnh lý của bệnh nhân, đặc biệt là có một số máy theo dõi kháng trở thận lồng ngực của bệnh nhân. Nếu trường hợp bị kháng trở tăng do suy tim, tăng hoặc giảm do suy tim thay đổi thì có thể có những cái báo động để bác sĩ điều chỉnh thuốc thích hợp. Thì những cái báo động rõ ràng nhất là nó giúp xác định sớm những cái cơn loạn nhịp như là rung nhĩ hoặc nhịp nhĩ, những cơn loạn nhịp thấp, và đặc biệt là như đã nói là cái việc mà suy tim tăng lên do mất hiệu quả tái đồng bộ. Chúng ta biết khi đặt cái máy tái đồng bộ cơ tim là cái máy tạo nhịp bao buồng, đôi khi có hiện tượng nó mất dẫn thì cái việc tạo nhịp nó sẽ không có hiệu quả. Ngay cả khi chúng ta đo điểm đồ, chúng ta thấy nó vẫn còn tạo nhịp tim bình thường, nhưng mà nó không còn đúng là tạo nhịp hai buồng thất nữa, thì cái hiệu quả suy tim thì suy tim không còn, và nhân có thể tăng cái nền suy tim. Thì một nghiên cứu người ta đánh giá, người ta thấy là cái tỷ lệ bệnh nhân bị loạn nhịp nó không triệu chứng rất là cao. Ngày xưa thì mỗi lần bệnh nhân không có máy thì chúng ta phải gắn Holter theo dõi, tuy nhiên cái nhược điểm của Holter là chỉ có theo dõi trong 24 tiếng. Ngày nay với cái máy tạo nhịp thì người ta thấy là tỷ lệ mà bị những bệnh nhân có cái máy tạo nhịp hoặc máy phá rung thì cái tỷ lệ loạn nhịp khá là cao, chiếm đến 35%. Thì cái việc phát hiện này rất quan trọng, bởi vì chính những cơn loạn nhịp này nó lại làm tăng cái nguy cơ đột quỵ. Mà nếu không phát hiện sớm thì như Dr. Liêu có nói, nếu phát hiện sớm chúng ta dùng thuốc kháng đông kịp thời thì nó ngừa cái biến cố bị thuyên tắc hoặc là đột quỵ. Thì cũng chính vì vậy có một nghiên cứu người ta thấy là khi mà áp dụng cái phương pháp home monitoring theo dõi từ xa thì có thể giảm được cái tỷ lệ tử vong và tỷ lệ nhập viện cho bệnh nhân ở những bệnh nhân đã có máy ICD và CRT-D là 50%. Thì chúng ta sẽ tự hỏi là tại sao đặt ICD mà còn giảm tỷ lệ tử vong nữa, thì hoặc CRT-D thì dễ hiểu là khi chúng ta phát hiện sớm suy tim, chúng ta điều trị tích cực thì bệnh nhân có thể giảm tỷ lệ tử vong. ICD cũng vậy, vì có nhiều cái cơn loạn nhịp mà nếu mà chúng ta để 3 tháng 6 tháng mới kiểm tra thì chúng ta sẽ chậm trễ việc dùng thuốc chống loạn nhịp, mà có thể bệnh nhân vì những cái cơn đó mặc dù là không có vào rung thất thì sốc điện mình biết ngay, tuy nhiên vào những cơn nhịp nhanh ngắn vậy nó tái đi tái lại lâu ngày, nó đưa đến cái tình trạng suy tim tăng lên. Thì cũng chính vì vậy cái khuyến cáo của Hiệp hội Tim mạch bên Hoa Kỳ thì người ta đã đưa cái chỉ định theo dõi home monitoring vào class 1A là những cái khuyến cáo cao nhất, xác định cái lợi ích nó vượt trên nhiều so với rủi ro. Thì khuyến cáo nói rằng tất cả các bệnh nhân có cấy các thiết bị điện tử tim mạch nên được đề nghị sử dụng thiết bị theo dõi từ xa. Do đó chúng ta thấy là cái bên trường hợp như Singapore thì rõ ràng người ta đã thực hiện đúng cái chuẩn mực, và cũng là một cái điều rất khá là tiếc đối với bản thân chúng tôi và Hiệp hội Tim mạch Việt Nam nói chung là chúng ta chưa có đẩy mạnh được do cái điều kiện thực tế, và chưa đẩy mạnh được cái việc theo dõi như thế này để đạt được cái chuẩn theo dõi bệnh nhân đặt thiết bị tạo nhịp ở Việt Nam. Vấn đề tiếp theo là mặc dù đã có home monitoring nhưng mà câu chuyện nó không đơn giản, bởi vì có home monitoring như các bạn có thể thấy nó là một cái thiết bị nó cũng không quá to nhưng mà cũng là cồng kềnh, nó không phải giống như cái điện thoại nhỏ nhỏ. Do đó khi mà đem theo bên người bệnh nhân thì nó gây ra cái phiền phức. Do đó một số bệnh nhân là đi xa thì không đem theo, hoặc là ví dụ đi công tác, đi vô chỗ làm việc thì cái máy để ở nhà, thì do đó là gây ra cái chuyện là trên 51% bệnh nhân thì không có mang theo cái máy để truyền tín hiệu liên tục về tổng đài theo dõi, và bệnh nhân đi xa vài ngày thì lại càng không theo, càng đi công tác, đi hội nghị thì người ta để cái máy nhà luôn, khỏi mất công vướng víu. Thì chính trong những cái thời gian đó thì bệnh nhân không có được theo dõi liên tục, nghĩa là không có tận dụng được hết cái công năng của cái home monitoring, chiếm tới là trên 50% là bệnh nhân không có được giám sát từ xa liên tục. Thì đặc biệt là cái chuyện này nó còn nghiêm trọng hơn đối với những trường hợp bệnh nhân mang máy ICD và CRT. Thì cái câu người ta nói đơn giản là cái điện thế càng cao thì tăng càng lớn, nghĩa là những cái máy này nó dùng cái năng lượng cao khác hẳn với cái máy tạo nhịp thông thường. Thì cái hệ thống này thì nó càng có những cái phức tạp thì lại cần phải theo dõi liên tục. Thì từ đó sinh ra cái chuyện làm sao để giải quyết vấn đề đó. Thì ngày nay nhờ cái tiến bộ của kỹ thuật, người ta có cái cách theo dõi bằng những cái app trên điện thoại kết nối với cái máy ICD hoặc CRT. Thì đây là những cái thế hệ mới thì người ta cho cái sự kết nối mạnh mẽ giữa cái điện thoại thông minh smartphone thì chúng ta biết ngày nay ai cũng có smartphone rồi, do đó cái việc theo dõi nó rất là dễ dàng. Như cái trong bài trình bày cũng có đề cập là cái công nghệ linh động đi đâu cũng tiện, bỏ vô túi là chúng ta có thể theo dõi, chỉ cần bấm nút truyền cái tín hiệu về trung tâm theo dõi thôi. Thì cái này dùng cái kỹ thuật là nó nhờ cái tính năng của điện thoại từ xa, giúp được giám sát từ xa và liên tục chỉ thông qua những cái app đơn giản thôi. Người ta bấm nút và send transmission thì nó đi về cho bệnh nhân. về cái tổng đài. Thì cái nhờ những cái app này thì nó giúp khuyến khích cái bệnh nhân là tuân thủ rất là tốt, là theo nghiên cứu thì người ta thấy là nó đạt tới là trên 97% bệnh nhân mà có cái home monitoring này được theo dõi giám sát từ xa bằng cái ứng dụng. Nhờ vậy, nhờ cái việc giám sát từ xa mà tuân thủ tốt cái việc giám sát từ xa thì dĩ nhiên là cái hiệu quả lâm sàng nó sẽ tốt hơn, bệnh nhân được giảm cái số lần nhập viện và lâu dài cải thiện cái tỷ lệ tử vong do những vấn đề như suy tim hoặc là nhịp gây ra. Thì trong cái của Abbott thì ta có những cái hệ thống gọi là My Moline Pulse, thì kết nối cái thiết bị và truyền thông tin, giúp cho cái can thiệp sớm hơn. Người bác sĩ khi nhận được thông tin chẳng hạn như bệnh nhân có cái rung nhĩ thì chúng ta lập tức là có thể mời bệnh nhân vào để cho thuốc chống loạn nhịp. Có những cái cơn loạn nhịp thất thì chúng tôi có thể cho thuốc chống loạn nhịp thất, hoặc bệnh nhân bị suy tim thì có thể điều chỉnh thuốc điều trị suy tim sớm, tránh để bệnh nhân khi mà suy tim nặng quá mới nhập viện thì đó có khi phải vào cái phòng cấp cứu nữa và tăng cái tỷ lệ tử vong sau đó. Thì cái ứng dụng này nó có thể kiểm tra liên tục cái tình trạng kết nối giữa cái điện thoại và cái thiết bị của bệnh nhân, và nó gửi dữ liệu thì chỉ cần bấm cái nút thì bệnh nhân có thể gửi dữ liệu về cho bác sĩ, do đó cái communicate nó liên tục. Dĩ nhiên chúng ta thấy nó cũng đặt vấn đề là khi có cái hệ thống này thì người bác sĩ phải tăng cái công suất làm việc lên, thì bệnh nhân gửi dữ liệu hoài mình phải xử lý, phải theo dõi. Đó là cũng vấn đề đặt ra ở Việt Nam, là làm sao chúng ta có thể giải quyết đó, trong khi bác sĩ Việt Nam phần lớn là quá tải. Do đó là cũng cái trở ngại mà hiện nay chưa có phát triển mạnh cái hệ thống theo dõi từ xa tại Việt Nam. Thì ngoài ra có một điểm lưu ý là cái công nghệ sử dụng trong cái máy này là công nghệ Bluetooth. Thì có lẽ chúng ta biết công nghệ Bluetooth cũng là công nghệ không dây, tuy nhiên cái mức mà phát sóng nó mạnh hơn, cái đó nó làm tăng cái độ nhạy tín hiệu và kết nối mạnh hơn và nhanh hơn so với cái tín hiệu radio frequency của cái hệ thống kinh điển. Thì một cái điểm nổi bật của cái công nghệ không dây Bluetooth là cái tính bảo mật. Thì ngày xưa chúng ta cứ sợ cái chuyện kết nối không dây là bởi vì chúng ta tưởng tượng nếu cái máy tạo nhịp mà có thể kết nối một cái hệ thống bên ngoài không dây thì có một hacker nào đó người ta đứng gần một ông tổng thống, phó tổng thống gắn cái máy, người ta chỉnh làm cái máy nó sai thì có thể gây chết người và nguy hiểm. Thì do đó cần một cái hệ thống bảo mật rất là tối ưu. Thì đây là cái công nghệ Bluetooth, là công nghệ nó đáp ứng được cái tính bảo mật rất là cao. Những cái công nghệ này được sử dụng thậm chí là bên quân đội. Từ cái hệ thống này thì nhờ cái sự kết nối này nó đưa ra cái luồng dữ liệu đi từ bệnh nhân đến phòng khám đến cái cổng lâm sàng và báo cho bác sĩ có thể điều chỉnh ngược lại cho bệnh nhân. Tóm lại cái công nghệ theo dõi home monitoring theo tôi là một cái kỹ thuật tiên tiến, chưa được rất tiếc là chưa được ứng dụng nhiều Việt Nam. Và ngày nay nhờ cái tiến bộ của kỹ thuật, đặc biệt là cái việc kết nối qua điện thoại chứ không phải là cái thiết bị theo dõi kinh điển, nó tạo cho cái việc dễ dàng. Thì chúng tôi cá nhân tôi nghĩ có lẽ đây là những cái công nghệ tương lai và sẽ được áp dụng ở Việt Nam rất là trong thời gian gần đây. Xin cảm ơn chú Tô Đoàn, xin cảm ơn tất cả các bạn đồng nghiệp đã chú ý lắng nghe.
Tôi xin trân trọng cảm ơn một bài trình bày cũng rất là chuyên sâu về kỹ thuật nhưng rất dễ hiểu của bác sĩ Đỗ Văn Bửu Đan đến Bệnh viện Tim Tâm Đức. Như chúng ta biết thì việc mà ứng dụng các cái hệ thống theo dõi từ xa, các máy tạo nhịp, chúng ta cũng đã áp dụng ít nhiều tại Việt Nam bằng cái hệ thống này, hệ thống khác. Và chúng tôi thấy là ngoài các cái thông số rất là quan trọng về tạo nhịp mà hệ thống gửi email về cho bác sĩ thực hành hàng ngày, thì bây giờ đặc biệt với hệ thống Merlin của Abbott thì chúng ta có thêm một cái application bằng điện thoại và bệnh nhân có thể tương tác hai chiều với bác sĩ. Và thực sự trong quá trình theo dõi bệnh nhân, chúng tôi cũng đã có phát hiện một số thông tin khá lý thú, kiểu như là thấy một cái tần số nhịp xoang tăng rất bất thường ở một bệnh nhân CRT chẳng hạn, và sau đó gọi điện cho bệnh nhân thì hóa ra là suy tim thì cũng không đến nỗi nặng lên, nhưng bệnh nhân bị một cái đợt sốt virus và chúng tôi tư vấn là bác phải đi thử COVID ngay và khai báo sức khỏe để hệ thống y tế, không là sẽ gặp rất nhiều phiền toái vì như vậy. Và rất là cảm ơn bác sĩ Đỗ Văn Bửu Đan. Tôi có một câu hỏi dành cho bác sĩ Đan là tại Thành phố Hồ Chí Minh hiện nay thì đặc biệt bởi vì Bệnh viện Tim Tâm Đức thì các anh chị có theo dõi bệnh nhân theo công nghệ từ xa không và sử dụng hệ thống của hãng nào?
Dạ thì thực tế các bạn có hỏi thì cũng xin trả lời là hiện tại là ở Bệnh viện Tim Đức chúng tôi dùng cái hệ thống của hãng Biotronic. Thì bên hãng Biotronic thì có lẽ có giáo sư Thống, thì tất cả các bạn đồng nghiệp trong tim mạch và đặc biệt trong lĩnh vực loạn nhịp thì biết là giáo sư rất là tích cực hỗ trợ Việt Nam. Thì chúng ta biết là cái vấn đề theo tôi vấn đề mà theo dõi monitoring nó không khó về kỹ thuật, nhưng mà khó về tính cái cách quản lý dữ liệu, bởi vì cái dữ liệu phải được gửi về trung tâm theo dõi và báo cho bác sĩ liên tục. Thì cái chuyện đó thì hiện tại ở cái bệnh viện Việt Nam chưa thực hiện được, do đó bên công ty là cần cung cấp. Nhưng mà khi chúng tôi làm việc với lại bên công ty Medtronic hoặc công ty bên Sensuit hồi trước và giờ là Abbott, thì bên đó người ta lại vướng những cái vấn đề pháp lý gì đó, người ta lại không chưa có tích cực hỗ trợ cái việc đó. Do đó là cái lý do mà và chúng tôi được bên giáo sư Thống giáo sư Thống và chị Dung bên Medtronic hỗ trợ rất là nhiều. Và hiện tại là chúng tôi có khoảng theo tôi nhớ là khoảng 3-4 ca theo dõi. Thì những cái trường hợp đó là những trường hợp là đặt cái máy khá là mắc, ICD với lại CTD. Thì lý do là khi mà trong trường hợp đó thì bên công ty lại cung cấp cái home monitoring cho bệnh nhân luôn free. Còn đối với những bệnh nhân mắc tuyệt nghiệp có theo dõi thì lại cần phải cái vấn đề đặt ra là phải nói bệnh nhân mua thêm cái máy. Thì chúng ta biết chẳng hạn như giờ cái máy nghiệp đã đặt rồi, sau đó chúng ta lại nói là giờ muốn theo dõi phải mua thêm cái máy. Thì đối với bệnh nhân thành thật mà nói có vẻ người ta sẽ ngần ngại, người ta cảm giác như mình làm cái gì đó mình đòi thêm một cái chi phí gì đó, trong khi người ta nghĩ là có khi cái đó là mình phải tự động làm cho người ta không hiểu chuyện đó. Do đó là hiện tại cũng chỉ áp dụng được cho những cái trường hợp mà đặt những cái máy mà khá là chi phí rất là cao và công ty hỗ trợ phần đó. Đó là cái tình hình ở cái riêng ở bệnh viện Tim Tâm Đức chúng tôi.
Vâng, thế ở bệnh viện Chợ Rẫy thì như thế nào, bác sĩ Phương sẽ chia sẻ?
Dạ, tại Chợ Rẫy của tụi em thì hiện tại vẫn chưa có triển khai hệ thống home monitoring hay là Bluetooth rất là hay giống như anh đang nói. Bởi vì đúng là nếu mà mình kết nối qua Bluetooth qua điện thoại thì bệnh nhân rõ ràng là không phải sắm thêm một cái thiết bị nào hết. Tuy nhiên cái vấn đề đặt ra thì ngoài vấn đề bảo mật, thế còn cái chính sách tài chính chi trả như thế nào, ai sẽ là người chi trả, bảo hiểm y tế có đồng chi trả cho bệnh nhân hay không. Em nghĩ đó là một cái vấn đề mà mình phải thuyết phục bệnh nhân rất là rõ, để cũng tương tự như bác sĩ Đan là họ sẽ không thắc mắc vì sao mình không tự trang bị cho họ mà họ phải bỏ tiền ra thêm. Hiện tại thì tụi em cũng chưa có cái hệ thống home monitoring nào và cũng không có liên kết với Biotronic giống như anh Đan. Thì thực sự đối với tụi em hiện tại thì cái monitoring chủ yếu đó là Zalo. Tụi em phải chịu khó cho số điện thoại, nhất là trong quá trình dịch để bệnh nhân có thể kết nối với mình. Tuy nhiên một con én không nằm lên mùa xuân, bệnh thì rất là nhiều, bác sĩ thì ít, Zalo thì quá tải. Do đó thì đúng là sự hiện diện của một hệ thống home monitoring, có một cái trung tâm, em nghĩ nó sẽ rất là cần thiết và nó sẽ trở thành hiện thực trong một cái tương lai hy vọng là gần.
Vâng, cảm ơn bác sĩ Phương. Thực ra thì đúng là Zalo đã hỗ trợ rất nhiều và chúng ta cũng phải dùng những công cụ đó trong thực hành. Nhưng mà Zalo thì nó giúp cho chúng ta biết được đến mức một điện tâm đồ bề mặt. Còn hệ thống monitoring thì qua các cái viễn lượng với hệ thống máy tạo nhịp có thể cho những cái thông số kỹ thuật chuyên sâu hơn. Và cảm ơn bác sĩ Lê Uyên Phương, và hiện nay chúng ta cũng đã có thêm một cái offer mới mà hệ thống theo dõi từ xa bởi cái của Merlin của Abbott, và cũng một lựa chọn với những cái tiến bộ về công nghệ chúng ta có thể cân nhắc áp dụng trong tương lai tại các trung tâm tim mạch lớn của chúng ta. Và quay trở lại, we have one more question for Dr. Zarina Liu. So what about the barriers in complementing the home monitoring in Singapore?
The barriers, the negative points or the inconveniences. Yes, I would say actually that there aren't really any barriers if the patients can be taught to use the system. The systems are all actually very easy to use, but they need to have a connectivity at their home. And Singapore, and as I'm sure with Vietnam as well, is very well connected. And usually the actual remote monitoring platform is very easy to install in their home, connect up to their device. And then once it's connected, the doctor in their clinic can actually so no real barriers, but there needs to be some connectivity. Often with my older patients who may not be as tech savvy, their children or relative will help connect for them. But the idea is really to minimize the inconvenience so that patients don't need to worry. Once it's connected, they shouldn't have to do anything other than know it's monitoring at the background. Occasionally, the doctor may contact the patient to say, look, can you send me a transmission? Or if the patient has any symptoms, they may want to send an elective transmission as well, but they don't have to.
Well, thank you very much for your answer. Cho tôi cũng hỏi là với những ưu điểm hệ thống theo dõi từ xa như vậy thì có những cái trở ngại gì ở Singapore không? Thì bác sĩ Lưu bảo là rất ít trở ngại vì Singapore là một nước cũng có một công nghệ và nền tảng viễn thông tốt cũng như Việt Nam các bạn. Và thứ hai nữa là mọi người cũng đã quen thuộc và tương đối dễ sử dụng một khi đã install, tức là cài đặt hệ thống. Tuy nhiên là vấn đề ở chỗ là ở một số bệnh nhân cao tuổi, người ta có thể không quen sử dụng các thiết bị di động, thì con cháu họ có thể hỗ trợ, và nói chung là hệ thống tiện lợi, ít gặp các trở ngại. Tuy nhiên trong thực tiễn Việt Nam thì mọi thứ có thể sẽ khác hơn. Thank you very much for your attention. And một lần nữa xin trân trọng cảm ơn các bạn đồng nghiệp, các vị chủ tọa đoàn, bác sĩ Janila Lưu đến từ Singapore, bác sĩ Đỗ Văn Bửu Đan ở bệnh viện Tim Tâm Đức và thạc sĩ Trần Lưu Phương đến từ bệnh viện Chợ Rẫy đã tham gia với các phần trình bày cũng như bình luận hết sức lý thú. Và bây giờ là thời điểm chúng ta sẽ đã đến điểm kết thúc của hội thảo hết sức lý thú ngày hôm nay. Một lần nữa xin trân trọng cảm ơn các vị khách mời và cảm ơn các bạn đồng nghiệp đã quan tâm theo dõi. Thank you very much and goodbye.
Thank you. Bye bye.
Thank you very much. Goodbye, everybody.
Thank you. Bye bye.
Goodbye, Dr. Liu.
Dạ.
Bye.
Bye Phương, chào Phong.
Dạ, chào Lan, chào anh Phong. Dạ.
Anh Đan nhớ giữ gìn sức khỏe nhá.
Ok.